Dear colleagues, good morning. I'm Sofia Mavrogeni, and on behalf of the Greek CMR organization, the Greek College of CMR, I welcome you in our course, which is Athens CMR Level 1-2. In this course, which is endorsed by ACVI and SCMR and accredited by EBAC with 21 CMEs, we'll do our very best to present this modality, the clinical application, the pro and contra, and we hope that we can give you an entire knowledge on this field. Enjoy the case. Thank you.
Kalimera.
Good morning.
Good morning, everyone.
Good morning.
May I first extend my sincere thanks and congratulations to Sofia Mavrogeni for once again organizing a most elaborate event. It is very good to be here, and without further ado, let me welcome our first speaker, which is Professor Anthony Aletras. He's Director and Professor of Biomedicine and Imaging Technologies at the Aristotle University of Thessaloniki, and at the same time, he's a researcher at the Division of Clinical Physiology in the University of Lund, Sweden. Professor Aletras, Kalimera. We again will have the privilege and pleasure to hear you on a subject that has remained basics for some, 2, 3, 4 decades now, basics in cardiac MR. The subject is also a very deep, a very demanding subject. Frankly speaking, from this day last year when I had the privilege of introducing you again, I don't think I have gotten any better in the CMR basics. I'm sure you're going to enlighten us more, certainly myself. So please go ahead, welcome, and we're waiting for a spectacular lecture on CMR basics. You have the stand. Thank you.
Thank you, Mr. Chairman. We have a few slides to help additional than last year and some more time. So I would like first to thank Dr. Mavrogeni for the invitation to be here with you today. And let's see, here are my disclosures. So our goal today is to understand how to generate a magnetic resonance signal. We would like to understand the tissue properties T1, T2, and T2 star that modulate, that change this signal. And then we would like to figure out how we can form an image from this signal. But before we get started, let's make sure we speak all the same language. MRI is all about spinning vectors, so it is important to know about the properties of a spinning vector. In this blue box, you see a vector that has a magnitude of 1. In other words, its length is 1. The vector is spinning at a frequency of 1 hertz, so it completes one circle, full circle, every second. And on the right, you see the vector's projection on the x-axis, which is an oscillation, a cosine function. On this y vertical axis, we would have a sinusoidal function, but it's not shown due to space limitations. In this red box, you see a vector that has a magnitude of 0.5. In other words, its length is half than the blue box one. The vector is spinning at the same frequency, at the same speed as the one in the blue box, a frequency of 1 hertz of 1 cycle per second. And on the right, you see the vector's projection on the x-axis, which is a similar oscillation, but with half the swing because the vector is half as big. And in the green box, you see a vector with a magnitude of 1, same as in the blue box. However, this vector in the green box is spinning at half the frequency as the one in the blue box, a frequency of 0.5 hertz. Remember, frequency describes the speed of spinning. And from this green box, if we take photos of the spinning vector, then we could capture it, for example, when it has completed 80 degrees of the 360-degree cycle. You see it went from here to here. The angle between the vector and the horizontal axis, where the spinning started, is 80 degrees. So we say that this vector has a phase of 80 degrees. And at the bottom, you see the photo of a vector that has completed a full circle of 360 degrees, and this vector has a phase of 360 degrees. In the same way that you think of frequency as the speed of spinning, you can think of phase as the position of the vector at any given time when we decide to take a photograph. It's just expressed in degrees. So now we're ready. Let's talk about spins. The water molecules inside our tissues have two hydrogen atoms with a single proton in the nucleus that is positively charged. This proton, this nucleus, spins about its axis. This proton behaves like a small magnet, like a tiny magnet that spins about its axis. These spins inside our tissues are the source of the magnetic resonance signal. And if we manage somehow to encode this MR signal in three-dimensional space, then we get beautiful images of the heart like this one. So let's first describe what happens in a very simple way. All the spins, all these little tiny magnets inside the patient's tissues are pointing in random directions as you see at the top. In the bottom, we have the same picture but with vectors. Each vector mu represents one of the spins at the top. The patient then goes inside the MRI scanner. You can see here the strong magnetic field of the MRI scanner, the 1.5 Tesla big magnet that we use for cardiac imaging most usually, the so-called B0. Because of this static magnetic field that you see created by this big magnet, you see that the spins, the tissue magnets, align parallel or anti-parallel with this field, that is pointing up or down. There's about 6 in a million more pointing up than pointing down. Most of the spins cancel with each other. Here you see the resulting picture after canceling out the spins pointing up with those pointing down. The remaining 6 in a million spins are the source of the MRI signal. These are the ones, and only these, that will make imaging possible. A more accurate picture of reality, though still not true, is that the spins do not fully align with the magnetic field B0. You see here B0, and here are the spins. Instead, they spin about B0 on the surface of two cones. One cone is pointing up and one cone pointing down. We introduce a Cartesian X, Y, Z coordinate system so that we can display on our two-dimensional slides what's happening in 3D. You can see how the X, Y, and Z axis point with respect to the patient's head, most commonly. The job of the spins is to spin about any magnetic field they experience. They spin faster if the field is stronger, and this is given by the so-called Larmor equation here. And in a 1.5 Tesla magnet, the spinning is done at about 64 million revolutions per second, at about 64 megahertz. As before, most of the spins up and down cancel out, leaving one cone pointing up. And in the end, the remaining spins of the patient can be seen as a so-called net magnetization vector M, which points along the z-axis, parallel to the direction of the magnetic field. This net magnetization vector M wants to spin about its axis at the Larmor frequency, at 64 megahertz in this case. Why? Because it is made out of spins that actually do this kind of spinning. So far we've put the patient inside the magnet. We haven't done anything else. And now that the patient is in the scanner, we introduce a so-called rotating magnetic field B1. So this is the static field of 1.5 Tesla, and this is a new field that we introduce. This is done by a radio frequency pulse, the so-called RF pulse. Think of it as a very short version of the radio frequency transmitted to bring music to your radio. This rotating magnetic field is very small compared to the static field of 1.5 Tesla. This is only about 10 millionths of a Tesla. This radio frequency pulse is tuned on purpose to the same frequency that the spins spin. You can see the frequency of the pulse equal to the Larmor frequency. So it's on resonance to the Larmor frequency. Remember that the job of every spin is to spin about any magnetic field it experiences. So the net magnetization vector now has to spin about both the static magnetic field 1.5 Tesla and about the B1, the RF pulse. Here you see the trajectory of the combined spinning motions, which is pretty complicated. But in the end, the net magnetization vector is forced to come onto the XY plane. Remember, the net magnetization wants to spin about B0, and here is how the spinning about, inside these parentheses, about B1 is done. So it's not such a complicated thing, it's just the vector tipping down and spinning at the same time. Only here we don't see the spinning at 64 million revolutions per second. When the B1, when the RF pulse ends, the net magnetization vector is spinning on the XY plane. As a result of Faraday's law of induction, this spinning magnet generates a small voltage on a coil antenna that we place on the patient. And this is the magnetic resonance signal. This is the free induction decay. This is the so-called FID, which dies out exponentially with time. This exponential decay, this loss of signal, is because of spins interacting with one another. Remember, the net magnetization vector is the result of adding all the spins in the tissue. And they initially, when they come down on the XY plane, they point all in one direction. So, at that point in time, the signal is at its maximum. As time passes, the spin interactions, spins talking to one another, influence the local magnetic field, and some move faster in red, spin faster in red, and some slower in blue. They're fanning out, they're opening out, no longer pointing in the same direction. So the signal is less, but at this time point. And in the end, the spins point at every direction. And of course, at that point in time, the arrow is pointing here, the signal is 0. The exponential decay that we see depends on the T2 relaxation parameter. This is specific to every tissue and can change with pathology. For normal myocardium, it's about 50 thousandths of a second, 50 milliseconds. For edematous tissue, edematous myocardium, it's about 75 milliseconds or higher. We take advantage of T2 to image, for example, intramyocardial edema. And if we take into account the magnet scanner's field inhomogeneity, the lack of being the same at every point in space, then fanning out is even faster than what T2 alone does. T2 star is the relaxation parameter that describes both tissue signal loss and field inhomogeneity signal loss. And T2 star is about 20 milliseconds in normal myocardium. The dephasing and loss of magnetization on the transverse plane, on the XY plane, is only the result of an increase in entropy. It's chaos kicking in. There's no energy transfer. Let's talk about T1 a little bit. Right after the RF pulse, when the entire net magnetization is on the transverse XY plane, none is left along the z-axis. So the z component is 0. As time goes by, and here you see it, the magnetization along the z-axis slowly recovers exponentially. This is done slowly based on a tissue's relaxation parameter T1, which for normal myocardium is a little above 1 second. This type of relaxation along the z-axis involves energy transfer from the spins to the surroundings. And if we inject a gadolinium-based contrast agent, then this energy transfer can be faster, and T1 becomes shorter. We use this imaging for imaging perfusion in the myocardium and viability. Let's move on to creating images. In order to localize the MRI signal in space, we use the so-called magnetic field gradients. When we run current through the X gradient coil that's inside our MRI scanner, then the magnetic field inside the scanner is no longer homogeneous, is no longer the same everywhere. It changes linearly in the left arm, right arm direction. With the Y gradient coil having current through it, we can change the magnetic field in the nose, back of head direction. And with the Z gradient, we can change the magnetic field in the foot head direction. It's important to remember that with gradients, we control how fast the spins inside the patient will spin while the patient is inside the magnet. That is, we provide three-dimensional space with a unique property that we can exploit so as to create images. Let's take a look at the three processes we use to create an image in the three-dimensional space. Slice selection is the first one and allows us to generate signal only from the desired slice to be imaged. We turn on the Z gradients, and spins will spin at different frequencies as a result of that, depending on their Z location. This is the Z axis 1, 2, 3, 4, 5, 6, and these are the different frequencies. Suppose we want to image to get signal from the blue slice here at Z equals 3. Then all we have to do is see that the spins there are spinning at 64,000,300 hertz. So 300 hertz above 64 megahertz. So we decide to transmit the RF pulse at that frequency exactly, on resonance. And since only the slice at Z equals 3 is on resonance, with the blue color here, then only that one will create the FID signal. The rest of the body's tissues are not contributing to the signal. And such is the way that we've localized in one direction, along the Z direction. To localize along the X direction, we have to turn on the X gradient, and we do that at the same time that we receive the signal. Here you see the image we want to collect. It's a slice of bread, moist. You see that depending on the position of the spins along the vertical axis, you see, I'm confusing a little bit here. The x-axis is vertical. They have different frequencies. So look at the rows. For example, the black spins in row X equals 3 are spinning slower than the blue spins at X equals 6. Okay, remember, we do not have this image yet. We're looking at what happens in the tissue. We're basically cheating at this point in time, but that's okay. We're teaching stuff now. So each of these rows of spins transmits a separate signal with a different frequency. The black is transmitting at 300 hertz, the brown at 400 hertz, green at 500 hertz, and so on. Note that the strength of these signals, the swing up and down vertically, depends on how many spins are at each frequency. For black, you see there is 4 spins, so 4. For the next one, 5. For the green ones, 6, and so on. These signals are received and added together by the scanner's receiver coils that we've placed on the patient. So they're added together, and we observe this sum, which contains all of these signals together. This sum of signals is fed into a mathematical tool, the Fourier transform, the FT, that you see here, which can untangle the frequencies and show us each frequency's signal strength, how many spins are contributing. So we can tell how strong the signal is at each location along the x-axis. And frequency is location, because we know that correspondence because we turned on the x gradient. So basically, we get a projection of the anatomy seen here at the bottom. I flipped it so that it's on 90 degrees so that it's easier to see. We get a projection of this onto the x-axis. We can get more projections and along different directions and reconstruct an image in the same way that they do in CT, in computed tomography. Or in most cases with MRI, we can do phase encoding. Now that we're done with two of the directions with slice and frequency, let's look at the third one with phase encoding. So phase encoding localizes the signal along the y-axis. We already saw that phase is a fancy word basically for angle. And remember that frequency can be seen as the speed of a car, for example, and phase as the distance traveled. Think, for example, of 6 car drivers next to each other racing. We now care about the distance each of the cars traveled instead of their speed. So we turn on the y gradient for only a short period of time before we receive the MRI signal. So this essentially tells each car driver to push on the gas pedal for a short period of time and then go back to their original speed driving as before. So now we're looking at the columns inside the tissue. You see, this is the y-axis, so we're looking at the columns. Car drivers on the left with blue push less on the gas pedal compared to drivers on the right with red. You can see that the clockwise rotation of spins in columns from left going to right is increasing. More distance traveled in the right columns, more angle covered, more phase. So each of the columns now has its own unique phase. So are we done? Is the y direction properly encoded? We're done with the third direction? Unfortunately, we're not. When all these vectors are added into a receiver coil, there is no way to untangle them. You see here down on the left an example. Let's say that this is the summation of the vectors at the top going from A to B. There are infinite different ways that we can create this sum. So we cannot untangle these vectors. We cannot find a unique solution. So somehow we need to convert phase into frequency, convert location into speed, which we know we can handle. Let's see how. So first we ask the drivers to go to the start line and then to increase their speed for a short period of time. Because of the y gradient that we have turned on, the further away to the right, the faster the driver and the car, the spins. We've seen this. From left to right, each column of the spins has faster spinning. As a result, when the short period of time of speeding is over, we see increased phase accumulation from left to right with these black vectors that represent each column. So, for example, at y equals 1, the leftmost column, we have 10 degrees. The second column at y equals 2, 20 degrees. Third column at y equals 3, 30 degrees, and so on. Each vector's length down here depends on how many spins contribute at that location, at that column. But we do not see individual columns in the end. We see the addition of these vectors as we discussed before. And this sum, this addition, is useless by itself, as we have already seen. But we take a photograph of it anyway. And then, when that is done, when that first experiment is done, We ask now all the drivers to go back to the starting line, and this time to increase their speed for the same short period of time as before, but now double speed compared to before. When the short period of time of double speeding is over, we see increased phase accumulation again from left to right with the red vectors. At y equals 1, this column is now 20 degrees. At y equals 2, it's 40 degrees. Y equals 3, 60 degrees. Again, each vector's length depends on how many spins contribute at that location, at that column. But notice how the red phases at each y location are doubled compared to the black ones of the previous slide, because they did use double the speed, our drivers. And again, the red vector sum by itself is useless to us, but we take a photograph of it again anyway, and we keep it. When we're done with this experiment, the second experiment, we ask again all drivers to go back to the starting line, and this time to increase their speed for the same short period of time, but now with triple speed. When the short period of time of triple speeding is over, we see increased phase accumulation again from left to right with green vectors this time. At y equals 1, 30, y equals 2, 60, y equals 3, 90, and so on. Notice again that the green phases at each y location are 3 times the black ones that we saw initially, because their speed was triple during that short period of time. And again, we observe the sum, which by itself is useless, but we take a photograph of it anyway. Last time, I promise, when we're done with that experiment, we ask the drivers to go back to the starting line, and this time for the same short period of time to increase their speed, but now quadruple compared to the one in black. When the short period of time is of like 4 times speeding is over, we see the increased phase accumulation again from left to right with blue vectors this time. I know these are a little hard to see. At y equals 1, 40, y equals 2, 80, y equals 3, this column 120 degrees, and so on. Notice again that the blue phases at each y location are 4 times the black ones, because we asked the drivers to go at 4 times the speed for that short period of time. And again, the blue vector sum by itself is useless, but we take a photograph again anyway. If we now look at all the additions together, then we have a new vantage point. Each location contributes with a specific rate of change of phase across experiments, across repetitions. At y equals 1, we get a rate of 10 degrees per repetition per experiment. At y equals 2, we get a rate of 20 degrees per repetition. At y equals 3, that column, 30 degrees per repetition, and so on. But look, the rate of change in phase is, in fact, frequency. It is the same as saying that the rate of change in position of an object is the speed of an object. So the rate of change in phase is frequency. And we know that the Fourier transform can untangle frequencies. However, this has a cost, this phase encoding business. These repetitions take time to do. These are different experiments. So this makes MRI a relatively slow imaging method. Let's take a look at frequency encoding and phase encoding from a perspective of making a video from photographs taken one after another. If we have 2 cars at the starting line and we use a camera from our cell phone to take pictures at regular time intervals, then these photographs will capture the position of the 2 cars as time passes. If we take these photographs and stitch them together with a dotted line there, stitch them together, then we have a video loop coming out of this, and we can estimate their speeds. This is how frequency encoding works in terms of capturing the data we need. Phase encoding works differently. So at the top of this slide, above the red line, we keep the photographs that make up the video we just saw so that we have a reference for comparison. With phase encoding, we ask the drivers to go back to the starting line, and then we tell them to go. We take a single photograph, and that's it. We stop. We then ask the drivers to go back to the starting line again and go, but double their speed. And then we take a single photograph at the exact same time as before, and again end this experiment. Again, we ask the drivers to go back to the starting line and go with 3 times the speed. We take a single photograph at exactly the same time as we did before and end this experiment as well. We do this a couple of more times, right, with quadruple speed asking of the drivers and 5 times the speed being asked of the drivers, but we always shoot the picture at exactly the same time as we did before. If we look carefully, the single photographs here that we shot during each experiment contain the same information as the ones we have for reference up here at the top, on top of the horizontal line. So we can stitch these together, right, and create a video of the racing cars where we can estimate their speeds. This complicated way to create our video is how phase encoding works in terms of capturing the data that we need for our imaging. And if we take all the frequency encoded signals from all the different phase encoding experiments and put them together in a raw data matrix, it's 2-dimensional because we have many experiments, we have the so-called K-space. And if we do a Fourier transform along both the vertical and the horizontal directions of K-space, then we can get our image. So in conclusion, I believe CMR physics are fun. When you understand the physics, you can manipulate image appearance in order to better show pathology, and you can understand where artifacts come from. Yes, MRI has more complex physics than any other imaging modality, but it also has more versatility than any other modality. Thank you very much.
Thank you so much, Professor Aletras. This was a highly scientific presentation. We all became more knowledgeable, and well, what can I say? I attended each and every slide of yours with the utmost care, and I think all the attendings did. It also must have taken you a great deal of time to make such a presentation. I don't have any questions. I think that your presentation spoke for itself. If there are any other, if there are any questions from the audience, I don't see anything in my chat box. So I thank you once again. It was great to see you, even if online. And let me pass on to Dr. Verganelakis. I'm glad to see you, Dr. Verganelakis. I'm glad that you resolved your issues with your laptop. You have a stand.
Yes, thank you very much for the introduction. Good morning to everybody. Today is the 4th of October. I would like to welcome also everybody to Athens CMR level 1 and 2. And right now I would like to introduce Dr. Xanthis, who is an electronic engineer and has substantial experience in simulation of MRI. Dr. Xanthis has worked on pioneering ideas regarding the simulation of MRI in education, research, and diagnosis. So I'm looking forward to his presentation. Dr. Xanthis, please.
Good morning. My name is Christos Xanthis, and today I'm going to give you a presentation entitled Sequences Used for CMR Imaging and Experience on a Virtual MRI Scan. Before I start, I would like to thank the organizing committee and in particular Dr. Sofia Mavrogeni for this opportunity. Unfortunately, due to other commitments, I was unable to give this presentation in a live session. My presentation comes in two parts. In the first part, we're going to talk about sequences that were frequently used for CMR imaging. In the second part, I will talk as the CTO and co-founder of a startup company, a Swedish startup company named Korsmen, and I will show you how a virtual MRI scanner can be used by technologists and cardiologists so as to get familiar and practice on cardiac MR imaging. Professor Anthony Aletras will answer any questions that you may have for the first part of this presentation, but I will be happy to answer the rest of the questions through email. I will turn off the camera for the rest of the presentation so as to give enough space for the slides to present important things for you. As I mentioned earlier, the first part of this presentation is going to be about sequences frequently used for CMR imaging. Before I start my presentation, I would like to show you these slides in this artificial graphical user interface that presents on the left side a cardiac MR protocol. I will present this slide again at the end of this presentation, and I hope that by the end of this presentation you will become more familiar with all the items listed in this protocol, such as tissue characterization, stress perfusion, rest perfusion, late gadolinium enhancement, and so on. This presentation will cover topics such as scout imaging and triggering, cine imaging, black blood CMR, first pass perfusion MRI, late gadolinium enhancement, tissue characterization or in other words T1, T2, T2 star and ECV mapping. But also we're going to spend just 3 slides at the end of this presentation where we're going to present some other techniques such as phase contrast for deflow and myocardial tagging. A standard cardiac MRI examination will start with initial screening of the patient and setting up of cardiac gating. This will be followed by MRI with initial quick scout localizing images and a stack of relatively rapid survey images through the chest. This will be used in order to obtain an initial overview of the heart and the associated intrathoracic anatomy. After identifying the location of the axis of the ventricles in 3 dimensions, basic static or cine images are required of the heart in standard short and long axis orientations, as well as various optional images as indicated by the specific clinical question. Cardiac triggering, also known as cardiac gating, synchronizes the acquisition of an entire set of case-space data at approximately the same portion of the cardiac cycle in order to overcome blurring of images which is caused by myocardial contraction and flow effect from pulsatile blood. The devices most commonly used for cardiac triggering are the ECG devices and other peripheral monitors, and the cardiac gating can be either prospective or retrospective. Although ECG gating removes the effects of cardiac motion, respiration also substantially changes the position and the shape of the heart, causing blurring artifacts and ghosting artifacts in the phase encoding direction. When the acquisition is short enough, breath holding can be used to eliminate artifacts due to respiration. Breath-held acquisitions, however, only work with cooperative patients. In all the other cases, we can use navigators which gate data acquisition to a specific part of the respiratory cycle. Most commonly, a linear navigator acquires data along a column in the superior-inferior direction through the diaphragm. Diaphragm position along the superior-inferior direction is quantified and used to determine the respiratory phase. Acquisition during the same respiratory phase over multiple respiratory cycles will provide consistent heart positioning. The ability of MRI methods to synchronize the image data acquisition with the cardiac cycle, as described before, permits reconstruction of high-quality movies, otherwise known as cine imaging. These movies are movies of the different phases of the cardiac cycle, even though the imaging data may be acquired over the course of multiple cardiac cycles. This is usually a gradient echo or balanced FP-based sequence, and the scene acquisition can be either retrospectively or prospectively gated. In the cases where we have multi-slice acquisition, interleaved acquisition are typically faster than sequential acquisitions because multiple slices can be acquired between triggers. For cine, several slices are grouped together and acquired at each cardiac phase. The same group of slices is repeated for the subsequent cardiac phases after each trigger. MRI can be used also for diagnostic purposes in the heart where anatomical information is needed. In such cases, it is advantageous to explore the versatility of MRI pulse sequence programming in order to produce images of a single cardiac phase where the blood pool appears black. This is called black blood CMR, and the main aim of such an approach is to suppress the signal coming from blood so as to improve the delineations of the surrounding structures. This technique is based on a fast spin echo sequence and can be used in conjunction with other contrast mechanisms such as T1 weighting and T2 weighted in order to produce images for tissue characterization and for the detection of intramyocardial edema or fat infiltration. As you can understand, the contrast in the image is created through blood signal suppression while preserving the signals arising from the surrounding tissues. A simplified pulse sequence diagram for black blood CMR is seen in the upper left figure. As you can see, this pulse sequence can be separated in two distinct parts. The so-called double inversion spin preparation, which occurs right after the detection of the R wave of the ECG device, and the readout, which occurs during late diastole. There are three basic concepts contributing to blood suppression in this pulse sequence. The first one is the tendency of the fast spin echo sequence to suppress moving spins. The second one is the null signal point during the inversion recovery. And the third one is the exchange of blood within the slice of interest. The double inversion spin preparation, in conjunction with the fast spin echo readout during diastasis, can give high-quality black blood contrast diagnostic images. However, in some cases, it is also possible that it can lead to misdiagnosis as a result of image artifacts that are not easy for the less experienced reader to identify. These artifacts may include bright blood that is caused by an ineffective blood suppression due to a reduced contractile function in the diseased heart, or a posterior myocardial signal loss due to either a long fast spin echo readout or by an inappropriately timed fast spin echo readout or a combination of the two above, or a signal loss due to through plane motion. As you can understand, image quality becomes a matter of selecting appropriate imaging parameters on a patient-by-patient basis, depending on expected findings, heart rate, and the ability for the patient to hold his or her breath during the image acquisition. An appropriate set of imaging parameters is dependent on the clinician's and technologist's experience. This is the main reason why some imaging sites routinely acquire quality images, while newly established facilities do not do as well. Another application in CMR is the first pass perfusion MRI. Myocardial perfusion imaging has undergone steady improvement since it was first introduced over 20 years ago. Myocardial perfusion is an important measurement in the diagnosis and management of coronary artery disease. Myocardial perfusion imaging is based on measuring the delivery of contrast agent to the myocardium during the first pass following a bolus injection. A bolus of contrast agent is injected in a peripheral vein and contrast enhancement is observed as the bolus passes through the myocardium. A non-selective 90-degree RF pulse suppresses the myocardial signal and then imaging is performed. Mathematical analysis of the shape of the time signal intensity curve measured in the myocardium is used to quantify the tissue perfusion in ml per gram per minute. In figure that you can see on the right side, we can see four phases for a multi-slice imaging acquisition in the short cardiac axis using an interleaved gradient echo planar imaging sequence. In the first image on the top left corner, the image signal intensity has been suppressed through the use of the saturation preparation pulse. In the second image, the image with the letter B, the contrast agent can be seen just entering the right ventricle. In the third image, with the letter C, contrast can just be observed entering the left ventricle. In the fourth image, you can see enhancement in the left ventricular myocardium, except in the region of subendocardial ischemia, where you can actually see the arrows. Slightly delayed imaging of the tissue after the bolus injection can be used in order to assess for inflammation or other sources of increased enhancement. However, a longer delayed imaging of enhancement can be used to bring out areas of infarction or scarring. The workhorse technique for myocardial characterization has been late gadolinium enhancement, or otherwise known as LG, which is routinely performed in MRI centers around the world as an integral part of nearly every cardiac MRI exam. The pulse sequence diagram can be seen in this figure, and you can see that this is an ECG-triggered pulse sequence where signal acquisition is performed during diastasis in a segmented manner with gradient echoes over several cardiac cycles. This type of acquisition provides diagnostic quality gradient echo images that have been T1 prepared by the inversion pulse. Approximately 20 k-space lines are acquired following every inversion pulse within a given cardiac cycle. A heartbeat is usually skipped to allow for T1 recovery before another inversion pulse is applied. The contrast of these sequences is optimized by inversion with an inversion time that zeroes the signal that comes from the healthy myocardium. The inversion time is determined beforehand in a dedicated sequence, otherwise known as TI Scout or Look Locker, in order to test a range of different TI values so that the user can choose the TI with the best suppression of the healthy myocardial signal. LG usually happens around 15 to 20 minutes after gadolinium administration, and this TI is usually around 300 milliseconds. One of CMR's key unique advantages is the possibility of tissue characterization. Current sequences are usually weighted to a specific magnetic property like T1 relaxation for scar imaging or T2 relaxation for edema visualization. However, the area of tissue characterization is a rapidly developing field. In the last few years, newer techniques, otherwise known as T1 and T2 mapping techniques, have been developed and advanced rapidly. These techniques provide colored pixel maps where each pixel represents the corresponding T1 or T2, or in T2 star mapping, the T2 star values. The main advantage of these techniques is that if performed correctly, they can provide an easy way to exchange data between different imaging centers and allows for defining thresholds between diseased and healthy myocardium. The first technique is called T1 mapping. To make the long story short, I will skip the description of basic MRI physics regarding T1 relaxation, since Professor Aletras has already given an extensive description on these concepts. In order to quantify the T1 values, an inversion recovery experiment needs to be performed multiple times so that several points along the inversion recovery curve can be acquired. Then fitting of the resulting images with an exponential curve on a pixel by pixel basis can give us color maps where the T1 values of each pixel can be visualized. For example, in this case, in the map that you can see on the right side, you can see that, for example, the pixels with the color, with the red color, will have a T1 value around 1600s, and pixels of myocardium with a light blue color will have T1 values around 1000 milliseconds. The most commonly used T1 mapping technique in CMR today is a modified Look Locker technique. This method is otherwise known as MOLI, and a MOLI pulse sequence diagram can be seen in this figure. As you can see, this pulse sequence is an ECG-triggered pulse sequence, and a non-slice selective inversion RF pulse inverts all the magnetization upon the detection of the R wave. Different time points of the inversion recovery curve are sampled after multiple cardiac cycles with single-shot SSFP images, which last around 200 milliseconds. Following a pause so that the magnetization can recover, the inversion is performed again and more single-shot images are acquired at different inversion times so as to sample different time points on the curve. After a second pause, in this example of 3 heartbeats, a third inversion pulse is applied and 5 more balanced SFP images are acquired in a similar manner as we described before. Since this is the last inversion pulse, 5 images are acquired instead of 3. At the bottom, you can see the 3, and 5 inversion recovery images obtained in this manner. Then we combine these images And by using also the inversion time for each one of these images, we are placing these images on the correct time spot of the inversion curve, and then we are fitting these images on a pixel by pixel basis in order to acquire these colored maps that I presented earlier. Here we can see another technique for T1 mapping in the heart, the second more frequently used T1 mapping technique in CMR protocols, and this one is called SASA. This method is based on a saturation. It's a saturation-based technique compared to the IR-based technique of MOLI. But also in the literature, you may find also other T1 mapping techniques with other acronyms such as AIR, SAPPHIRE, SMOLI, and so on. However, the most frequently challenges in T1 mapping today is that all these different T1 mapping techniques do not give the same T1 results in terms of accuracy and precision. The main reason for this is because all these techniques are being affected by several factors, but also because of the post-processing technique that we choose at the end in order to generate these colored T1 maps. An extension of T1 mapping is ECV mapping. Multicellular organisms are built of cells embedded in the interstitium. In disease, the ratio between cells and interstitium changes due to interstitial expansion as a result of increased collagen or accumulation of exogenous material such as amyloid. In most organs and diseases, diffuse fibrosis plays a key role, and fibrosis quantifications may guide therapy. CMR measures focal fibrosis by using late gadolinium enhancement, but this method is unable to quantify diffuse fibrosis. T1 mapping can now non-invasively quantify this myocardial extracellular volume, or otherwise known as ECV, which in turn reflects diffuse fibrosis. ECV mapping is based on the fact that the contrast agent does not cross the cellular membrane and that after injection remains primarily within the extracellular space. So by acquiring T1 maps before and after the administration of a contrast agent, and by using this formula that you see at the top right corner of these slides, and also the hematocrit value, then we can generate these ECV maps where each pixel, the color of each pixel, represents a different ECV value. In this figure, we can observe examples illustrating an excellent agreement between LG and TCV in cases of focal abnormalities in myocardial ECV. In this figure, the first row presents the pre-contrast T1 maps, the second row presents the post-contrast T1 maps, the third row presents LG, and the fourth row presents the corresponding ECV maps. As you can see in this figure, there is a very good agreement between the LG images and TCV maps for focal fibrosis, but you can see in the diffuse fibrosis cases that LG presents a weakness where the ECV brings some value for the case of diffuse fibrosis. In a similar manner with T1 mapping, T2 and T2 star mapping is about acquiring points along the T2 and T2 star relaxation curves, and then fit these images on a pixel by pixel basis with these mathematical equations in order to estimate the T2 and T2 star values on a pixel by pixel basis, which are being represented using similar colored maps as we presented for the T1 mapping. T2 weighted MRI pulse sequences have been used in order to detect edema in patients with acute myocardial infarction and differentiate acute from chronic infarction. The pulse sequence commonly used in CMR for visualizing intramyocardial edema is based on a turbo spin echo, or otherwise known as a fast spin echo pulse sequence, where multiple spin echoes are created by a train of equidistantly spaced 180 RF pulses. However, T2 weighted sequences have suffered from several problems, including signal intensity variability, which is caused by phased array coils, or high signal from slow-moving ventricular chamber blood that can mimic and mask elevated T2 in subendocardial myocardium, or motion artifacts, or also the subjective nature of T2 weighted image interpretation. An alternative approach to T2 weighted imaging is to directly quantify the T2 of the myocardium. This can be done by using quantitative T2 mapping, where the artifacts associated with T2-weighted imaging may be minimized and small T2 differences between tissues may be more easily detected. Rapid T2 mapping of myocardial tissue has been accomplished by means of the T2 prepared SSFP method in a single breath hold. The idea is being presented in this diagram, and it's very basic. It's based on collecting 3 images with different preparation times so that 3 different points of the T2 exponential decay can be measured. Once we have these 3 different points, we put these points along the relaxation curve, and then we are fitting these images on a pixel by pixel basis with the equation, the mathematical equation that describes the T2 relaxation, and then we create the color map that you can see on the right side, where each pixel, the color of each pixel represents a corresponding T2 value. In a similar manner, T2 star mapping allows the quantification of T2 star. T2 star contrast has been shown to provide insight in diseases that are associated with an increased deposition of iron in the tissue, such as in cases of thalassemia. Such images are relatively easy to acquire by means of traditional gradient echo imaging with long echo times and long repetition times. However, it was the T2 star mapping, where the actual values of the T2 star relaxation characteristics are known, that has revolutionized the manner by which patients with thalassemia are treated. Mapping the T2 star values in the myocardium and the liver allow for guiding the treatment. In order to obtain T2 star maps, gradient echoes have to be used since they depict local field inhomogeneity, which in turn increases with increased iron deposition. In these cases, multiple gradient echoes are acquired by rephasing the spins multiple times after a single excitation. Then we are grouping these echoes together, and we are acquiring different images with different T2 star contrast, and then again, as we did also for T1 mapping and T2 mapping, we are fitting these images on a pixel by pixel basis with the equation that describes the T2 star decay, and then we generate colored maps where the color of each pixel will represent the corresponding T2 star value. Before I close the first phase of this presentation, I would like to describe or to mention very briefly 3 other techniques that you may find in a CMR protocol. One of these techniques is phase contrast, which is being used for imaging of moving magnetization, and it can be utilized by the application of flow encoding gradients. Actually, it is a gradient echo pulse sequence where we are repeating the same experiment twice, each time with an opposite bipolar gradient polarity. Then we perform a phase subtraction of the 2 resulting images, and in these cases, when phase images are displayed using the conventional grayscale, stationary tissues is depicted as mid-gray, flow in one direction is depicted at shades of mid-gray to black, and flow in the opposite direction is in shades of mid-gray to white. Another technique that you may find in CMR protocols in mainly more advanced cardiac centers, it is the 4D flow, which is a 3-dimensional time-resolved 3-component phase contrast CMR technique. It is mainly used to study blood flow patterns, to quantify kinetic energy, and for particle tracing. It is performed offline, and it allows an offline flow quantification, visualization of vascular anatomy, and it is usually a segmented gradient echo sequence. Last but not least is myocardial tagging, which allows us to visualize the contractility of the heart. Myocardial tagging usually uses a single pulse sequence, but we have already played a spatial selective excitation pulse in order to spatially modulate the magnetization within the imaging slice. A simulation example can be seen in this video, where you can see that the black lines follow the contractility of the heart, but also you can note the gradual loss of contrast between the bands and myocardium throughout the cardiac cycle due to T1 relaxation. This slide brings me back to the first slide that I presented to you at the beginning of my presentation. By now, I believe that you have become more familiar with the different items that you may find in a basic cardiac MRI protocol. A basic cardiac MRI protocol will start with the localizers that will help you to obtain an initial overview of the heart and the associated intrathoracic anatomy, but also to identify the location of the axis of the ventricles in 3 dimensions. Then you can continue with tissue characterization, which is actually T1 and T2 mapping. And then after the administration of contrast agent, you can perform stress perfusion and rest perfusion. These two can be combined together in order to measure myocardial flow reserve. In the meantime, while you are waiting for 15 to 20 minutes before you acquire the LG, then you can run cine imaging in order to obtain the structure of left ventricle and its function. At the end of this protocol, you can acquire more T1 maps that you can combine with the T1 maps that you acquired before the administration of contrast, so as to generate ECV maps. Of course, at the end of this protocol, you can add more pulse sequences such as phase contrast imaging, 4D flow, myocardial tagging that will answer the clinical questions that you have for that specific patient that you have into the scanner. The previous slide was the last slide of the first part of my presentation. From now on, we're going to change the subject of this presentation and we're going to talk about the experience on a virtual MRI scanner and how young and senior cardiologists can utilize a virtual MRI scanner, or otherwise known as an MRI simulator, in order to get trained in practice on basic and advanced cardiac MR protocols. For the rest of this presentation, I will talk to you as the co-founder and CTO of CourseMed, a Swedish startup company which started as a spin-off company from Lund University in South Sweden. CourseMed is an impact startup focused on creating equality in quality healthcare on a global scale. Founded in 8 years of research from Lund University, we focus on improving the efficiency of medical imaging, more specifically MRI. Our current focus is building a training platform for professionals practicing MRI. The problem that we have identified and we are trying to solve in CourseMed has to do with education in MRI. In particular, MRI is a two-step process. First, technologists create images by running the scanner. Second, radiologists or cardiologists in CMR cases analyze the images to determine pathology and treatment needed. Running the scanner is a manual and skill-based process. High-skilled technologies create high-quality images in a short amount of time. Low-skilled radiographers create low-quality images in large amounts of times. Low-quality images are a huge issue in most of the hospitals, being the main reason for an insufficient flow and potentially patient risk. In a similar manner, high-skilled radiologists will be able to tell the difference between a clinical finding and an image artifact, or in cases of quantitative MR, to assess correctly the quantitative measurements. High-volume, continuing hands-on practice is frequently said to be the main driver for high skill in MRI. This is true on all levels in an MRI technologist and physicist career, going all the way from university students to experienced professionals in clinic. Students practice the basics while the experienced are exploring and testing the latest method. Whichever level, continuing hands-on education is the main factor driving high and consistent skill. However, getting enough hands-on practice is difficult, which is due to the lack of available scanners and volunteers. Actually, the main issue is that MRI scanners are extremely expensive, and this will limit the availability to practice on them. In other words, there is a large gap between the availability and the need for practice hours. For this specific reason, we spent more than 8 years researching MRI simulations to develop the CourseMed MRI simulator. An MRI simulator to run and practice MRI without actual access to real scanners. More easily described, it is a virtual MRI scanner, or using our favorite metaphor, it is the flight simulator of MRI. So, how does it work? Well, running the MRI simulator and practicing on it is just like running and practicing on a real scanner. You use similar interfaces and work with the same features, settings, and parameters in the same way as you would do on a real MRI scanner. We have focused on 3 things when we developed our technology. One-to-one, no limitations, and always accessible. So first, one-to-one. 1 hour on the simulator should give you the same experience as 1 hour on a clinical MRI scanner. By using similar interfaces and parameters and by giving the same resulting output, you get as much experience using the simulator as a clinical scanner. To re-emphasize, if you input the same parameters into the simulator as you would do in a clinical scanner, you get the same output image, including field of view, anatomy, resolution, scan time, SNR, contrast, and artifacts. There are no image banks. On the contrary, every image is simulated from scratch, so you can create any images that you want. Second, no limitations. You can practice as much as you want. Every user has its own account and can use the platform for any numbers of hours during the year. Third, it is always accessible. You can run the simulator from any computer without downloads or installation. The software is built to be run in web browsers on our cloud servers, so you can use the software from any connected computer. So whether it is a university student looking to learn the basic or professional with 10 years of experience looking to test and train the latest method, this educational tool is the go-to choice for everything that regards safe and efficient training and practice in MRI scanning. In this slide, we can identify the main components of the educational tool. It consists of 3 image viewers where the user can place the acquired image and prescribe the plane or plane for the next experiment. On the left side, there is the MR protocol, and on the right side, there is the area where the user can modify the parameters of the pulse sequence. Of course, there are other tools and features within the graphical user interface, but these are the main components. Currently, the educational tool comes with 2 versions. One with an anatomical model of the human body and one with an anatomical model of the human head. The educational tool allows also the utilization of cine imaging. Our anatomical model allows for cardiac motion and respiration. We have developed a cine sequence based on BSSFP so as to image the beating heart throughout the cardiac cycle. In this example, the simulator has generated cines in single breath holds for a 4-chamber view and for 3 short axis views, apical, midventricular, and basal. Each cine consists of 20 frames, whereas the heart rate of the computer model was set to 60 BPM. The educational tool allows for the simulation of the first pass myocardial perfusion by presenting the delivery of contrast agent to the myocardium during the first pass following a bolus injection. The simulator calculates on the fly the T1 values of the myocardial tissues as the contrast agent passes through the heart. The calculations take into account several parameters such as the contrast dose, characteristics of the Fermi model, and etc. The introduction of pathology will allow us to introduce regions of subendocardial ischemia. Therefore, in these cases, enhancement will be seen in the left ventricular myocardium, except in the region of subendocardial ischemia. The educational tool allows also for tissue characterization through the utilization of mapping techniques. In this example, you can see the single-shot BSSFP images acquired at different time points along the inversion recovery curve in a 5-3-3 MOLI scheme and the corresponding T1 map. The user can define the MOLI scheme, the properties of the balanced period out, the type of the inversion pulse, and so many other parameters. More mapping techniques are currently under development, such as SASA for T1 mapping and T2-PREP BSSFP for T2 mapping. ECV mapping could also be introduced with the introduction of pathology. What we have presented so far covers only a narrow part of the spectrum. In the past, we had built flow models and simulated images were generated by applying a phase contrast velocity encoded gradient echo pulse sequence on the flow model. We had also utilized myocardial tagging using a cine GRE sequence as I presented in the first part of my presentation. The educational tool supports a variety of anatomical models. This includes anatomical model of males and females at different size, with or without cardiac motion and respiration, with the arm up or down. The anatomical models support also the introduction of pathology, such as myocardial infarction for cardiac applications or tumors within the body. Last, T2 star simulation and susceptibility weighted imaging are already available in our simulation models. The cardiac model that we have built Also allows the user to define the properties of the cardiac cycle and can introduce also myocardial infarction. Two more tissue types are introduced, which is the salvage myocardium and infarcted myocardium, and variable position of MI within LV is allowed. This allows the educational tool to introduce new methods and sequences such as late gadolinium enhancement, contrast enhanced FP for visualization of myocardium at risk, and TCV mapping with the acquisition of T1 maps before and after the administration of contrast agent. Moreover, other T1 mapping techniques such as SASA and T2 mapping techniques such as T2 prepare balance FP will soon be available. Here I'm going to give you a short presentation, a short demo of how you can utilize the educational tool. And in this lab, the main purpose of this lab is to give an increased understanding for cardiac imaging. Moreover, the outcomes relate also to understanding manual slice positioning in cardiac MRIs, such as short axis and long axis planes, but also cine imaging, first pass perfusion, and quantitative MRI. As you can see, we have found through the localizers the position of the heart, and then we are going to acquire a pseudo two-chamber view in order to acquire next a pseudo four-chamber view, and then using that image to acquire short axis slices through the left ventricle. As you can see, every time that we move the plane in one of the viewers, the plane updates on the other viewers, and then once we click the run button, the simulation, the advanced simulation, runs on the cloud on powerful computers, and the images are being presented in one of the image viewers. In this case, we acquired the pseudo two-chamber view. And based on this image that will be presented on the right viewer, we are going to acquire a pseudo four-chamber view. So in this case, we are going to clone the pulse sequence that we ran last. We are going to rename it so as to identify it later in the MR protocol and remind us what we ran during this experiment. And then we are going to position the slice correctly so as to acquire a pseudo fourth chamber view. Again, you can see that as we move the plane on the right image viewer, the plane updates in the other two viewers. We run the experiment and then we're gonna place it on the left viewer. You can see the blue box along the left viewer, which actually shows that viewer is the active viewer. And then we are cloning this pulse sequence in order to acquire a stack of short axis slices that cover the entire LV. I will not run this experiment now. I have already run it for you, so I'm gonna load it directly into the left image viewer. And actually you can see all the different short axis slices that are acquired through the stack. And this covers apical slices, mid-ventricular slices, and basal slices. You can see also in the pseudo four-chamber view on the right viewer how the position of each slice changes while I'm changing that specific location. This is an example of a cine pulse sequence that we acquired for slice number 9. And now I'm gonna also present the first pass perfusion example that we ran previously on the educational tool. And actually you can see how the contrast changes as the contrast agent passes through the myocardium, through the heart and through the myocardium. And also here I will present you a MOLI pulse sequence that we ran. You can see the different BSSFP images. You can also know the different contrast because of the different inversion times, and also you can see the resulting T1 map that was generated based on that specific configuration on the MOLI pulse sequence. And also this is another tool that we provide through the educational tool, and through this tool you can actually download the images either as JPEG or PNG format or as DICOM images that you can import in another DICOM viewer. Here also you can place ROIs. In this case, we are placing an ROI on top of the myocardium into the T1 map, and actually we can measure in real time the T1 value of the myocardium, in this case, which is around 900 milliseconds based on that specific configuration that we used for molly pulse sequence. Of course, the educational tool comes with other features and other internal tools. It's very difficult for us to describe all of this within one session, but another tool that we find quite beneficial and important for our users is what we call a 3D viewer, where you can actually see in a 3D viewer where you have placed your slice with respect to other slices or with respect to the anatomy with the computer model that you have into the scanner. Of course, you can activate and deactivate other MRI aspects such as chemical shifts, susceptibility, T2 star effects, and so on. This is a simulation platform, so this is the added value of using a simulator, is that you can isolate specific effects and only utilize the ones that you think that are more important for you and for learning specific aspects of the MR experiment. This brings me to the end of this long presentation where we actually cover two different topics. I would like to thank you for your attention, and please feel free to send me questions in my email that you can see at the bottom of this slide. If you have any questions with respect to either the first part of this presentation or the second part of this presentation and the educational tool that CourseMed provide. Thanks a lot.
Really very interesting and exciting presentation by Dr. Xanthis. His presentation was pre-recorded, so right now Dr. Xanthis is not available to answer any of your questions. So if you agree, Dr. Vrachliotis, we can move on to our next speaker, who is Dr. Papanastasiou, who is currently a data manager, a manager in data science, in the Center for Digital Innovation of Pfizer in Thessaloniki, in Greece. Dr. Papanastasiou's interests, research and development, include artificial intelligence algorithms, machine learning in the areas of decisions, computer vision, advanced statistical and computational modeling. And his aim regarding his research is to develop different biomarkers to improve early diagnosis in different pathologies, to monitor response to new treatments and therapies, and to support also, finally, drug discoveries. So, please, Dr. Papanastasiou, I invite you to the podium.
Good morning. Thank you very much for the introduction, Dr. Verganelakis. I hope you can hear me and see my screen.
Yes, we do.
Hello?
Yes, everything is fine.
You can see my screen?
Yes, we do.
Okay, that's great. Thank you very much. So, as mentioned, I am currently, my name is Yorgos Papanastasiou. I'm currently working for Pfizer, but I don't represent Pfizer today. I join with my academic research hat on, as all the material that I will present has nothing to do with Pfizer material. It's something that I had to specify for my disclosures. Very briefly, to describe who I am and how I am relating to cardiac MRI, I have worked in the past and currently on developing R&D processes for computational and imaging and image analysis techniques in the field of medical physics and medical informatics. And the aim there is to customize and develop and customize imaging protocols. So at the end of the protocols, we can derive imaging biomarkers in the field of quantitative cardiology and radiology. I also have worked extensively with developing AI models to interrogate big data and see how we can extract information from different vendors, MRI vendors, or other imaging modalities vendors, different sites, and different acquisition techniques, and how to combine this information with molecular profile data many times, depending on the project. There were great presentations from Professor Aletras and Dr. Xanthis, and I will follow up and tighten some of the previous conversations on MRI physics and applications with some clinical applications and hopefully provide some insights there. So as you know, MRI is in the family is among the most used imaging techniques in the clinical setting, and cardiac MRI is a very important subsection of MRI. My talk today will focus on mapping techniques, which means how we can derive clinically quantitative information. Dr. Xanthis gave some information about this already. And before going into the details of quantification of image analysis and quantification and imaging biomarkers, let's catch up from what Professor Aletras was discussing before on how you can manipulate the speed of individual spins and get an image. This is in the context of describing what we call net magnetization, which kind of helps to understand how we manipulate signals in MRI to develop different mapping techniques such as T1, T2, T2 star, perfusion, and a couple of other mapping techniques that I will present. So as discussed in MRI, we monitor the magnetic behavior of the hydrogen nucleus. And that's because we have, that happens in conventional MRI, because we also have spectroscopic MRI or other couple of other types of MRI. But today we discuss about hydrogen MRI, the most used technique actually. So we have millions of hydrogen atoms because we have water in our body. And the hydrogen atoms have different concentrations in tissues, organs, and fats. And that's what we're trying actually to reveal. Each hydrogen atom is a single positively charged proton, and each proton its hydrogen atom or proton has a nuclear spin, which is an intrinsic property of an atom that makes it rotating around itself and creates a very tiny magnet, a tiny magnet. These tiny magnets, which means its hydrogen atom or spin, are randomly oriented within our body when we are the way we lie at the moment, where we're not exposed to an external magnetic field. And so because they have a direction, each of these has a direction in the rotation movement, we say that the direction of its spin in the absence of an external magnetic field is canceling each other, because we have high chances of getting, if you have one spin having this direction, you have high chances of having the spin going towards that direction, and so they cancel each other. And so you say that the net magnetization is zero. This is not the case when we have a strong external magnetic field, which occurs inside MRI. When you have 1.5, 3T, or 7T, which is very much used in neurology, the latter, but not only, you have a strong magnetic field. What it does is it aligns the protons, the spins or hydrogen atoms, in two possible orientations, which are also known in the literature. They are also called eigenstates. You may see this term. There are quantum mechanics involved, but we're not going to speak about quantum mechanics. We are satisfying. We describe all these processes, and we understand what happened by using classical mechanics, and more specifically, this Boltzmann equation here gives an estimation of how many protons lie in the parallel versus the anti-parallel orientation, because you have these two possible states. When you enter a magnetic field, when you enter a scanner and you're exposed to magnetic field, there are two possible orientations. The one is the parallel, the other is the anti-parallel. According to classical mechanics, the parallel orientation, what it means is that in the parallel orientation, few more protons rotate parallelly to the main magnetic field of the scanner. So imagine a patient that has a head here and the legs here. That's the main magnetic field of the scanner, and these are the spins that rotate in the parallel orientation versus the spins rotating in the anti-parallel one. So what happens is we have just few more protons, few more spins going in the parallel orientation, because it's of slightly lower energy versus the anti-parallel, And this slight increase in the spins that are in the parallel orientation creates the net magnetization. So if you do the subtraction, you have some more spins between parallel and anti-parallel. You have few more spins rotating here. And so we say that the organ is magnetized, and we call this net magnetization, the aggregation of spins that that are synchronized in the parallel orientation and are living here. And MRI, although it's not that easy, actually it is based on manipulating the net magnetization with many complex radio frequency pulses and gradients, many of which have been discussed by Professor Aletras. And so you see here what the process again is. You have the net magnetization here. So if we can use this illustration, and so the spins rotate here. You can send a saturation pulse or an inversion pulse. A saturation pulse means you send it to the XY plane. An inversion pulse means you send it to the -Z plane. And depending on what technique you use, you use either saturation or inversion, and you wait for this net magnetization to recover. And this is actually what we call T1 recovery time, which is characteristic for its tissue. It changes in pathologies compared to healthy tissues, and essentially depends on the water content and local molecular microenvironment. During T1 relaxation, during this process, protons interact with their surrounding tissues, and the absorbed energy, I forgot to say that the saturation or inversion occurs by sending a radio frequency pulse, which is strong enough to manipulate the signal that much. And it absorbs energy during that process. And when it goes back, it releases back this energy. And this energy, the absorbed energy from the excited protons, is the spins interact with their environment, and that's how they lose energy and they relax back. And that's why we call it spin lattice relaxation time. The lattice here is the surrounding environment of the tissue. Again, these things have been discussed, but I'm just giving this context to link it with the mapping techniques. In MRI, we have one challenge. Well, we had one challenge because this has been addressed. The heart is moving, so it takes quite some time in the range of seconds plus minus for the T1 recovery to come back. And so, because the heart is moving, we have cardiac noise issues to deal with. And so Mestrokli and colleagues back in 2004, they developed this amazing technique actually called modified loop-locker inversion recovery, MOLI, discussed by Dr. Xanthis, where actually what they were doing is they were doing briefer, shorter experiments of T1 relaxation time, 3 experiments in total, and they were much shorter, and they could trace different parts of this T1 relaxation time by using offsets through ECG gating. And so its perpendicular line you see here is in one image acquisition. And so at the end, from these 3 different experiments, they had 11 images tracing this T1 relaxation time. And because they knew the background of the mathematics, the mathematical relationships governing this experiment, they could very accurately quantify T1, and they validated this technique. And we had also validated this technique in our MR scanner in the University of Edinburgh. And it has been these techniques are widely validated, and we know their advantages. In few years later, the SMOLI technique came up, which is the shortened MOLI, and this came up to minimize MOLI sensitivity to heart rate, especially for patients with respiratory function compromise that they could not hold their breath for a long time. what we do in T1 mapping is that we are actually tracing, we want to quantify this difference between normal and abnormal. And that's an example here that you see native T1 values in the absence of contrast enhancement in the myocardium. And you see a patient who had an infarction here, and there was edema. And the green is coming from the healthy or remote myocardium, and the orange comes from the area with edema. So the larger this difference is, the more we can capture it on a pixel by pixel basis by fitting these exponential curves that Dr. Xanthis discussed before. And so we can measure in milliseconds the T1 relaxation time difference between normal and abnormal. Next to native T1, because native T1 cannot be used for everything, it's great for edema, but if you also want to measure other things such as fibrosis, scientists came up with a ECV mapping, extracellular volume mapping. And that's because it combines interstitial volume. It's a good measure of interstitial space, and so you can measure the increase of the interstitial space if there is fibrosis. ECV mapping represents a physiological parameter, and ECV mapping values are considered to be reproducible between different field strengths, vendors, and acquisition techniques, perhaps slightly more reproducible compared to native T1. But again, this is not to substitute native T1, this is to complement native T1, and that's a strength of MRI. It combines within half an hour different sequences to derive complementary information. For ECV mapping, what we do is we use a contrast agent, and we wait for some time until the contrast agent washes out from the healthy part of the myocardium. And by using this equation here, because in the fibrotic areas, contrast agent, the passage of the contrast is not occurring in a normal way. It is trapped in the fibrotic areas. This equation here is actually it represents here T1 myo post contrast is the T1 in the myocardium after contrast enhancement. This is normalized to the post contrast T1 in the blood pool, and this is the T1 myo before contrast enhancement, the native T1, normalized to the T1 in the blood. So what happens is, because contrast is trapped in the fibrotic areas, this term is increasing, and so ECV is also increasing. And so that's one example to show here a paper that summarizes all these views is actually that we may have edema and interstitial space increase due to fibrosis, for example, or amyloid deposition even. And we don't know, if we do just native T1, we don't know whether we also have fibrosis. So we perform in ECV to disentangle this question. Do we also have fibrosis next to edema? And I'll show you some images later. One note here is that decreased native T1 values are mainly due to lipid overload or iron overload, and that's a good note to make here. And also decreased ECV values occur in the presence of thrombus or fat lipomatous metaplasia. So that's one example where you see increased native T1 and increased ECV. This is in the case of edema here. There is acute myocarditis, and you see a native T1 increase. But what you don't see in native T1 is these fibrotic areas. You see the red are showing the fibrotic areas, and the same agreement, but with complementary information in the same time. You see here an acute myocardial infarction with microvascular obstruction. This is what you see in the native T1, what you pick up. This is confirmed in the LGE as an infarction, and this is the red areas are the fibrotic areas that you see. And then you can monitor the plasticity of the cells if you repeat. If you have if you want to see myocardial viability, perhaps it's one way to see whether a few months later whether this fibrotic area remains the same, just to validate your results. T2 mapping is another very useful technique which offers both visualization and in vivo quantification of cardiac edema. And is a focus of current clinical research efforts. The T2 relaxation is actually this curve that you see here when we manipulate the net magnetization and we send it to the XY plane. Instead of focusing to trace the T1 mapping, we focus on tracing the spin-spin interaction, which is actually this decay of the curve. Oh, excuse me. It's this decay of the curve here, which is actually due to spin-spin relaxation this time. It's not due to spin lattice relaxation. These two processes, T1 and T2, occur at the same time with T2 being a much faster process compared to T1. So depending on the clinical setting and the clinical question, many times we want to do both, or we just want to do T2, depending on what works best. And I'm sure you'll see clinical examples later. I want to emphasize here that we are using these techniques to extract complementary information. T2 star mapping is another very useful technique that has been widely used in cardiac MRI. It is great for depicting hemorrhage or iron deposition, and many times, as this paper suggests here, is occurring next to T2 when you want to answer the question whether you have also hemorrhage. That's a case where you have edema here, because T2 is great for edema. Forgot to mention that in my previous slide. Is also next to T1 is T2 is also good for edema, and that's what you're picking up here. What you don't know is whether you have hemorrhage, so you do T2 star mapping. In that case, you don't see any hemorrhage in your values inside the myocardium. The values are homogeneous, but in that case, you see that next to edema, you also have possible hemorrhage because you have this heterogeneity in the pixel values, and you see this very light yellow here is corresponding to hemorrhage. BOLD is another very useful technique that is worth mentioning here. It's the only technique we have at the moment for assessing oxygenation in the tissues. The entire terminology is blood oxygen level dependence mapping, and that's one way to map the oxygenation levels in the myocardial tissue. It initially was not designed, but it was initially inspired for neurology applications for estimation of strokes. But very quickly it was adapted in the cardiac MRI field. BOLD contrasting MRI, the principle behind BOLD is that it is designed to reflect the differential deoxyhemoglobin content of blood in the myocardial tissue. The deoxygenated blood has higher content of deoxyhemoglobin, and as gadolinium is, deoxyhemoglobin is paramagnetic. So gadolinium is paramagnetic, we use gadolinium. Deoxyhemoglobin is also paramagnetic, and that's where BOLD lies on quantifying this paramagnetism coming up from the deoxyhemoglobin levels. And because it is paramagnetic, it causes strong field inhomogeneities that leads to evident MR signal loss. Most of the sequences used in the very beginning were T2 star based, but T2 weighted images are more and more used for BOLD imaging. There are customized T2 weighted sequences for BOLD imaging. So you trace the T2 relaxation time when you have deoxyhemoglobin versus highly oxygenated blood. A note here is that highly oxygenated blood is diamagnetic and causes no MR signal loss. And so this is increasing the signal intensity or maintains it. And so you want, again, to find this difference. This one example here, many times BOLD is happening at stress and at rest. And you do an index here. So you combine, you get the ratio of stress to rest. And many times it happens next to perfusion because you want to see whether you have ischemia and oxygenation. First, to understand whether these two agree. Second, because you want to see whether how extensive your ischemia is in terms of oxygenation levels. So you see here an ischemic event in this patient, which is actually confirmed in this stress to rest BOLD. In these areas, the BOLD index is lower versus the remote myocardium. The same is here. The negative means that the rest bolt is higher to the stress, and the same happens in that case here. Actually, this is the same patient at different uh, axis views, long axis views, short axis views, sorry. And that's DCMRI. We already discussed this in the previous slide. This is used for assessing blood flow. The mapping is actually focusing on quantifying the blood flow, not just getting the visual estimates. It is based on doing very quick dynamic imaging. That's why it's called dynamic imaging. You do very quick imaging to trace the passage of gadolinium through the different chambers of the heart. Here you see the first image. The gadolinium has been injected, but it has not yet arrived in the heart, in the left part of the heart. It arrives in the right ventricle. Through the lungs, it goes to the left ventricle, and then it enhances the myocardium. And so you can trace the first pass, and if you like, also you can extend it to slightly after the first pass and see how blood flow values and other estimates of tissue vascularity and permeability um, occur. Most of the times we use just blood flow as an imaging biomarker, and that's one of the things. That's the main thing we want to extract as an imaging biomarker from the DCMRI data. That's what happens when you inject a contrast in the arteries. Of course, that's a super simplification of what happens. This animation is a super simplification of what happens in our arteries. You can imagine that the networks are much more complex than this, but the blue spheres are the gadolinium molecules. They pass through the arteries into the interstitial space, and then they come back. The red spheres are the erythrocytes, so we don't care about these. We want to measure the passage of the blue spheres going through the artery system to the interstitial space and coming back. And we use mathematical models and also design mathematical models to trace this passage. By using mathematical models, also known as tracer kinetic models, we have seen excellent on rock statistics by using statistical assessments, excellent detection of ischemia, actually of obstruction of coronary artery disease. Many times we not only we can detect obstructive, but we can also detect non-obstructive, and the results are not perfect, but you see that the closer you are to one, the higher the sensitivity and the specificity of these techniques. This work was that it was in 1.5 Tesla scanner, and more or less it was showing no differences between the tracer kinetic models. When we repeated this work in 3T, we saw a difference between a more complex and a less complex tracer kinetic model. This leads us to the conclusion that many times you have to go deeper and understand what the data show you, what context you have, what spatial resolution you have, what temporal resolution you have to find the right tracer kinetic model to use. And that comes next to any kind of image analysis techniques you may be using. It requires some understanding, some expertise to develop this work. These tracer kinetic models have been validated against PET. The difference between PET is considered the gold standard for dynamic imaging. The main reason behind that, although it has technical problems and challenges, the main let's say advantage of PET is the fact that you have a direct relationship between what you see in the signal intensity of the image and the tracer you have injected. In MRI, there is no linear relationship between these two, and we have to use mathematics to derive, to quantify how much concentration we have, staging concentration we have in the tissue. But by validating our MRI tracer kinetic models against PET, we saw great agreements. And that's the last mapping technique I would like to present you today. is the manganese mapping. We had used manganese in the Endibra. It has been used before. We wanted to see how it works across different cardiac pathologies. We were using a very slow infusion of manganese to avoid toxicities. And we actually developed a tracer kinetic model to quantify manganese uptake. The main difference between manganese and gadolinium, which is the mostly used tracer, is the fact that you have manganese enters it enters the cardiomyocytes via voltage-gated calcium channels, and so it has high preference for living cells, for living cardiomyocytes, healthy cells, and that's the only way we have to image with a contrast agent in MRI the viable tissue. And these are some results you see here from a patient that had infarction. This is the LGE. This is the native T1. It gives you some very good agreement, but it does not give you the viability here. So we see this difference between the viable myocardium, the peri-infarct zone with the green, and the yellow, which is the infarct zone. And so we are detecting cardiomyocytes with manganese. This is the graphical. These are some more images from this work, where actually manganese was evaluated in different cardiomyopathies. The blue that you see there this is a graphical way to show the results. So essentially, the more you are to the left, the higher the uptake of manganese in the tissue. And so this is from healthy volunteers, and this is across different cardiomyopathies. And there was a consistent difference between healthy volunteers and different cardiomyopathies in the manganese uptake. And that's also the same work for myocardial infarction this time, where actually you see again that not only we can find the infarct zone, but we can also quantify the peri-infarct zone. And I think that's one of the main strengths, that you can find these three things in the myocardial infarction: a remote, peri-infarct, and infarct zone. So in conclusion, T1 mapping is very useful, mainly for detecting water content, and so you can detect edema. Many times it is used in combination with ECV mapping to enhance or complement the diagnostic performance of native T1, because you can also quantify fibrosis much more accurately. T2 and T2 star mapping are great for edema and hemorrhages, respectively. They are sometimes used in combination. And again, they are used in combination to derive this complementary information, whether you have edema and hemorrhages. These are two very characteristic examples of clinical application. Pooled mapping is the only way we have for abnormal oxygenation level detection. It has been used for different diseases. It has been used mainly for coronary artery disease, but it can be applied for many cardiomyopathies. And it is often combined with quantitative perfusion analysis. And finally, pharmacokinetic model mapping, or tracer kinetic model mapping, is useful to detect perfusion abnormalities or myocardial viability in cardiovascular disease across different cardiomyopathies or different cardiovascular diseases in general. I would like to thank you for the invitation, and I welcome any questions you may have.
Are there any questions? I don't know if you can listen to me.
I can hear you.
Okay, that's good. Yes. So if it was very interesting, all those mapping techniques that you discuss. So what do you think is going to be the future now of cardiac MRI? what's your opinion about the future, the current future, the near future?
In terms of
Dr.
scientific
Papanastasiou.
context, in terms
Yes.
of, thank you for the question. You mean in terms of scientific or context or clinical application?
Clinical applications, first of all.
I think one of the main strengths of MRI, as we discussed, is the fact that you can combine different mapping techniques, different sequences. You can change the physics to get different imaging biomarkers or surrogate biomarkers, and I think that's the main strength of MRI. The future, starting from there, is the fact that you can find more and more applications for cardiac MRI. And I think it's a matter of education, as discussed before, for cardiologists and doctors in general to be able to leverage all these experience that comes up from the MRI community and translate it. Because many times we use, for example, we do use lots of SPECT still, which is great. But you can do all these things without the complications of SPECT by using MRI and no radiation. We use lots of CT because it's slightly less expensive compared to MRI. But if we are going to use more MRI, will that make it also as cost effective as CT is considered in the communities? I think it's a matter of communicating. There is ongoing research. It never stops. It has a fascinating strength that you can combine you can extract different imaging biomarkers. You can have a very good idea of what happens with MRI using no radiation. You need experts to read the images. You need experts to develop the protocols, and you need experts to develop the image analysis. And you need experts for the education. So I think
it's a long sequence.
Sorry?
It is a long sequence of requirements.
It is a long sequence, but if we think about where this was 30 years ago or 40 years ago, when everything, when we had the first, let's say, ideas and images, perhaps, I think there's so much evolution
True.
already. And that's the dynamics of this, that we can see this thing happening
Yes.
more and more.
Yes. I think Professor Mavrogeni has got a question for you.
Yeah, absolutely. Hello, Sophie.
Excellent talk. And my question is, what will happen with low field CMR? Just because it seems more flexible and can be potentially part of the everyday practice of a cardiologist, exactly like echo. Is there any potential for the near future? I mean, next 30, 50 years, near future.
Again, I think it's a matter. I am very positive about these things, but again, it's a matter of going from the research into the clinical research domain, and then from the clinical research domain into the clinical practice. One of the main challenges is how you can develop at the moment with existing software and hardware and existing knowledge of physics and computer science. We can have excellent images in static MR, in scanners within hospitals. If we're speaking about modality, about scanners outside of the hospital, because I guess that's where your question goes, Sophie, right? Then, yeah, it's a matter of getting all these. Can we have the same signal to noise ratio there? Can we have the same quality of images? It's a matter of work and evolution there. Of course, there's potential, but it has to mature. It has to happen. It has to be validated as well.
Thank you.
Mr.
Yes,
President, can I ask
yes.
a question? Okay, there's potential for everything, actually. Now, you mentioned a sequence of prerequisites in order to guide MR in success. What do you think are the greatest hurdles in achieving the target and the goal you mentioned before. I mean, we've known for 40 years that MR, okay, it doesn't have radiation. And we also know that MR is a very, very slow technique. The first one cannot be solved because it has been solved by definition. So, what are we doing towards making things faster? Because one of the main problems with cardiac MR is A, beating of the heart is a shooting target, and second, time. Those, since you are a physicist and you are an expert in your field, where is the industry moving towards these hurdles, let's call them, not obstacles?
I will give you again an answer that is based on evolution, and thank you. These are important questions to address.
Well, actually, I think it's because you can, if you leave a patient in the magnet for 1 or 2 hours, then there's always a balance between what are you going to get versus how safe is it to keep the patient.
Let's give a couple of examples. If you think about where T1 mapping was 20 years ago, well, not 20, 20, because in 2004
Zero.
you had Molly.
Right.
It was T1, it was, you had to wait for maybe 2 hours to get something, to get something from one slide. And then Molly came, and you can do this in almost 16 to 15, on average 15 seconds. On 50 seconds, you can do excellent T1 mapping in the heart. And then with Molly, you can reduce it down to below 10 seconds. And so what you had to do 20 years ago for more than an hour to trace this recovery of T1 that we were discussing, nowadays you can do this so much quickly. So that's evolution.
Plus the hour and a half for the other sequences.
I wouldn't say that MRI is slow because
an hour and a half.
Sorry, once again.
Plus the other an hour and a half you had to add to those sequences 20 years ago. So now we're down to, let's say, 45 minutes, 1 hour. How low do you think we can get? Because in CT, as you mentioned, you only mentioned the matter of cost in CT. Well, there are much more other advantages in CT. So I'm not asking you to make a comparison, but since you're a physicist again and you're part of the developing industry, 45 minutes today is a good time, but still we need to make it better. How do you foresee that those 45 minutes will be reduced to 20, let's say?
I cannot do this prediction, but what I know again is that through examples we can understand how quickly this decrease of timing can decrease exponentially, not linearly. So if you think about what you had to do with T1 mapping, and then now you can do T1 mapping in a few seconds, it's kind of amazing thing. Another thing is how you can do perfusion. You can do perfusion, you can get temporal resolution of 1 second at the moment. And not only you can do temporal resolution of 1 second, so in each second you can do one image. But nowadays you can cover almost 3D of the heart. This was never possible 10 years ago. And at the moment we are in 30 to 40 minutes, but this decrease can happen exponentially, and that's my only prediction, the only prediction I can make.
Yes. Thank you. We thank you very much, sir. Now we got dwelled into this very interesting discussion. However, we omitted the most important thing. We have questions from the audience, and thank you for reminding us. Dr. Aletras, you're welcome to join in. We have two questions from Dr. Campos. They're all yours.
Yeah, if I could just throw in a 10-second response to the previous question. Aside from the tsunami of AI applications that are coming, I think that the simulation tools that Xanthis presented just earlier might become very useful into constraining the problem of making an image. What does that mean? For example, if you know that your image that you're going to collect is a circle, then the only thing you need to know is where that circle center is and what its radius is, and then you're done, right? If you know it contains only one circle. So similarly, the simulator can be used to constrain the problem and make things faster, hopefully in the future, near future, in the next 5 years or so. Anywho, there were two questions from Dr. Campos on. One was, well, what's the difference between Molly and Sasha, and why don't we use the Smalley all the time? Molly is based on an inversion recovery and multiple points being sampled after an inversion recovery, whereas Sasha is based on saturation recovery and only one point being sampled after the saturation recovery. So the idea is that Sasha is not dependent on what has happened in the past, because you always start from magnetization along Z of 0. It's the reason we use saturation recovery also for dynamic perfusion imaging. Okay, so it can be more accurate. Molly, on the other hand, because it collects more points, loses some accuracy, increases in precision. Why don't we use Smalley? Apparently, everybody at different facilities can have different numbers of T1 for Smalley, Molly. Sasha is more immune to that. So depending on heart rates, for example, Molly is sensitive to what numbers you're going to get out. And also the ECV numbers, the extracellular volume numbers that come out of these pulse sequences are really amazing to look at in some cases, where you look at, for example, normal myocardium being reported as having an ECV of like 30 or 28, when radioisotopes say it's around 19. So it's important to answer your question is because we haven't figured out how to use these, not all the sites at least, these pulse sequences after getting them at least validated locally. Unfortunately, this still needs to be done with these mapping techniques. When you see a number, it's not necessarily the right number. So the second question had to do with, can we look at viable versus non-viable myocardium? It is a lot of fun because I did a lot of this stuff during my postdoc and years at NIH. And the question here can be answered in two ways. You could use T2 intramyocardial edema imaging so as to look at the area that is both viable and non-viable. And a subset of that area, the non-viable part, you can look with late gadolinium enhancement. Okay, so you can have the difference between these two areas as the edematous, but not enhancing in the LGE part. Or you can use a contrast enhanced SSFP, which is much more robust to use compared to T2 imaging. I won't spend a lot of time because we just don't have the time. But yes, you can tell viable from non-viable myocardium within the area that was at risk of dying.
Okay. Right. Are there any more questions now? Because we're running out of time and we don't want this.
There's one last one. If you look at it, I think this is more from a clinical perspective. It says, how many patients with coronary artery disease are referred for cardiac MRI with a protocol that includes mapping techniques in clinical practice? This is for a physician to answer. How much would you say?
Most of them.
Depends on the facility, right?
But most of them, I would say.
So
Dr. Mavrogeni?
Yeah.
Dr. Mavrogeni?
Thank you for including me in the panel. The point is that since 2018, these indices are considered as clinical indices. They are not experimental indices, which means that they offer a lot of clinical information to physicians. So if they are available in a system, they must be used. Specifically in the field of cardiomyopathy, you miss a lot of information if you don't use these indices.
Verify and that they work properly on your scanner before you start.
Yes, and definitely you have to have your own normal values. Create your own normal values. Otherwise, it doesn't work.
So to break this down, this means that in our site, a normal myocardium may have a T1 of 1,000. At Dr. Mavrogenis, it could be 1,100.
Yes.
You know, depending on the parameters used, and
Yeah.
that's why you need a Molly, for example, with a good precision, but you have your own cutoffs at
Yes.
each site.
In
Eventually, I think
you should have your own controls.
eventually, hopefully, we'll reach a point where the techniques are matured enough that we all have the same normal values, because the normal value in the end reflects the myocardium, not the technique that's used to measure it.
Yeah, that's true.
Yeah, and that's again a matter of validation and education. That's why it's so necessary.
Good. Good. Any other question?
No? Okay. I don't know if
Yeah, I think all the ones on the site have been answered. Yes.
okay. So if there are no further questions, and if you all agree, we may conclude. Dr. Mavrogianni, do you have anything to add?
Great talks, great questions. I'm really very happy because so many people participate in this course and present their thoughts on this modality.
Okay, so thank you, Sophia. So may I close now? We attended 3 lectures of high scientific value. I think Sophia Mavrogianni once again followed a recipe of success in selecting the outstanding speakers that we heard. What I observed is that the slight overlap of content among today's lectures made the session progressively stronger and therefore more solid. Thank you, Sophia, for the invitation. Thank you all for being here, and enjoy the rest of the meeting. Thank you all.
Thank you.
Thank you very much.
Thank you. Thank you.
Bye-bye.
Bye.
Bye.
As a science company with 100 years of expertise in diagnostic imaging, Bayer are committed to developing innovative products, software and services to help you run and operate your department at a high level of care. With technologically advanced injectors for CT, cardiovascular imaging, MR and contrast media, our products are supported by our digital ecosystem with software that securely manages your detailed patient data, contrast data and scan data, enabling workflow solutions like contrast and radiation dose management and personalised smart protocolling. We offer all this with our expert service to ensure your radiology ecosystem is maintained to a high standard with remote support for rapid assistance. Our technologies come together as an end-to-end workflow solution with the aim of helping you achieve consistent scan results, increasing your diagnostic confidence and operational efficiency for the benefit of your patients.
There's no doubt a lot is changing in the interventional field. Pressure is increasing. More is asked of the team. We are treating more patients and more difficult cases with many different devices and applications that make it challenging to perform at a consistent level. So everything we do is organized to give us greater simplicity and control. We expect the same from our technology too.
Azurion was built to bring greater simplicity and also control to the interventional lab. It's not all about adding more functionality, it's adding functionality that matters in the most easy way.
During a coronary case, a lot of different systems are used, so normally you would continuously switch between systems and gathering all the information through those systems. And with Azurion, we were able to bring all those systems together in one interface. Azurion really gives you the control over the whole procedure in the coronary lab. With the one touchscreen monitor, you can operate as well the Azurion system, acquiring the angiogram and the physiology data to assess, for example, the severity of the stenosis, including the IVUS data to guide and confirm your treatment, for example, your stent placement. And when you also add a feature like co-registration onto that, you are able to connect and couple the information coming from the angiogram to the information that is coming from the IVUS to confirm whether the treatment was successful or not. Integration obviously reduces the amount of cable clutter in the lab, but also improves the workflow throughout the coronary procedure. And that is important because time, of course, is critical in such a procedure. The Azurion systems allowed easy repositioning of the X-ray system. While doing an angiogram, then full system APCs allows you to come back to that exact same position with just one press on the button. When a patient comes into your cath lab, nowadays he needs to be reconnected to a new patient monitor. We designed the Philips Hemo system in such a way that it connects to the IntelliVue X3 patient monitor. It then provides input to the Hemo system. And this unique combination enables continuous patient monitoring. The Hemo user interface uses Azurion's intuitive workflow approach. And besides that, clinicians can now also visualize and adapt vital signs and hemodynamic calculations at the table side. For the whole hospital staff, the procedure will become more easy. And now with the Azurion system, you can enter the patient information only once, and it will be shared across all the Philips products that you are using within that coronary procedure. That seems like a small improvement, but for the whole workflow it really saves time and it also prevents errors to be made. What is also beneficial for the hospital is that the whole Azurion system is now running on Windows 10, which offers, of course, great benefits with respect to cybersecurity, for example. Since we have all these products in our product portfolio, we can combine them in an optimal way, create a smooth workflow throughout the coronary procedure. Coronary procedure is complex in itself, so we do all the best we can to make that simpler for the user and to hopefully create better outcomes with that. Philips is the only one that can offer this level of integration.
It's really about getting a good view on what you're doing and knowing that you're right.
When the technology in my lab collaborates as smoothly as my team, my attention is free for what matters most.
Gene Pharm is a privately owned pharmaceutical company that develops, manufactures, markets, and distributes premium range generic pharmaceutical products on an international level. Originally, the company's business focus was primarily on the Greek market, where we have always sold direct to market under our own brand. We have come a long way since Gene Pharm was founded in 1967, having grown from a local to an international company, respected the world over. This is largely due to focused product development, flexibility in accommodating our customers' needs, and high standards in customer service. While Gene Pharm retains its position in the Greek market, having established solid relationships with local physicians and patients, its business extends globally via strategic alliances based on the development of new products. Today, our presence extends to over 90 countries through our collaboration with some of the most respected pharmaceutical companies in the world. Over the last 10 years, Gene Pharm's total investment in production facilities, research, and product development totaled 58 million euro. We operate from our privately owned facilities spread across 12,000 square meters close to Athens. The 3 state-of-the-art manufacturing units within our plant are segregated and dedicated to the production of conventional solid dosage forms and oncology sterile liquid dosage and solid dosage forms. Gene Pharm's quality assurance system, based on the strictest international standards, ensures compliance with all the regulations and specifications set by national and international legislation at all levels of manufacturing and product control. Our state-of-the-art production lines, along with the quality control procedures that are in place, comply with strict safety standards in order to deliver the highest level of quality, both of the raw materials and of the finished product. Over the years, we have gained significant experience in the regulatory affairs domain, which means that we can safely guide your candidate product through to successful submission. Gene Pharm is also a leader in the injectable oncology drug sector, with one of the most advanced production lines in Europe. Through continuous investment in the training of our highly skilled personnel and the development of new and innovative products and services, Gene Pharm aims to be a leader in the generics pharmaceutical industry. At Gene Pharm, we care about product quality, but most importantly, we care about people. Our objective is to continue to grow while offering high-quality products and services to the global pharmaceutical market.
As a science company with 100 years of expertise in diagnostic imaging, Bayer are committed to developing innovative products, software and services to help you run and operate your department at a high level of care. With technologically advanced injectors for CT, cardiovascular imaging, MR and contrast media, our products are supported by our digital ecosystem with software that securely manages your detailed patient data, contrast data and scan data, enabling workflow solutions like contrast and radiation dose management and personalised smart protocolling. We offer all this with our expert service to ensure your radiology ecosystem is maintained to a high standard with remote support for rapid assistance. Our technologies come together as an end-to-end workflow solution with the aim of helping you achieve consistent scan results, increasing your diagnostic confidence and operational efficiency for the benefit of your patients.
There's no doubt a lot is changing in the interventional field. Pressure is increasing. More is asked of the team. We are treating more patients and more difficult cases with many different devices and applications that make it challenging to perform at a consistent level. So everything we do is organized to give us greater simplicity and control. We expect the same from our technology too.
Azurion was built to bring greater simplicity and also control to the interventional lab. It's not all about adding more functionality, it's adding functionality that matters in the most easy way.
During a coronary case, a lot of different systems are used, so normally you would continuously switch between systems and gathering all the information through those systems. And with Azurion, we were able to bring all those systems together in one interface. Azurion really gives you the control over the whole procedure in the coronary lab. With the one touchscreen monitor, you can operate as well the Azurion system, acquiring the angiogram and the physiology data to assess, for example, the severity of the stenosis, including the IVUS data to guide and confirm your treatment, for example, your stent placement. And when you also add a feature like co-registration onto that, you are able to connect and couple the information coming from the angiogram to the information that is coming from the IVUS to confirm whether the treatment was successful or not. Integration obviously reduces the amount of cable clutter in the lab, but also improves the workflow throughout the coronary procedure. And that is important because time, of course, is critical in such a procedure. The Azurion systems allow easy repositioning of the X-ray system. While doing an angiogram, then full system APCs allows you to come back to that exact same position with just one press on the button. When a patient comes into your cath lab, nowadays he needs to be reconnected to a new patient monitor. We designed the Philips Hemo system in such a way that it connects to the IntelliVue X3 patient monitor. It then provides input to the Hemo system. And this unique combination enables continuous patient monitoring. The Hemo user interface uses Azurion's intuitive workflow approach. And besides that, clinicians can now also visualize and adapt vital signs and hemodynamic calculations at the table side. For the whole hospital staff, the procedure will become more easy. And now with the Azurion system, you can enter the patient information only once, and it will be shared across all the Philips products that you are using within that coronary procedure. That seems like a small improvement, but for the whole workflow, it really saves time and it also prevents errors to be made. What is also beneficial for the hospital is that the whole Azurion system is now running on Windows 10, which offers, of course, great benefits with respect to cybersecurity, for example. Since we have all these products in our product portfolio, we can combine them in an optimal way, create a smooth workflow throughout the coronary procedure. A coronary procedure is complex in itself, so we do all the best we can to make that simpler for the user and to hopefully create better outcomes with that. Philips is the only one that can offer this level of integration.
It's really about getting a good view on what you're doing and knowing that you're right.
When the technology in my lab collaborates as smoothly as my team, my attention is free for what matters most.
Good morning, dear colleagues. Yanni, good morning. Just a moment, please. Okay. We continue Athens CMR level 1 to 2 with the session CMR in coronary artery disease and cardiac remodeling. It is known that stress perfusion CMR is considered the gold standard for the assessment of ischemia and risk stratification of major adverse cardiovascular events in patients with coronary artery disease. Dr. Bratis, an expert in CMR, will enlighten us how to do and interpret. Dr. Bratis, hello.
Thank you very much. Good morning, everyone. Thank you very much for the introduction, Dr. Vartela. Let me share my screen and start my presentation. Can everyone see my slides, please? Okay, I think we are ready. It's a pleasure to be part of this panel on ischemic heart disease. We'll start this session with a talk on the fundamentals and the practicalities of setting up a CMR perfusion service, and especially how we prepare the patient, how we image him, and then how we interpret the images. So what we need, we are talking about a stress exam. It's in a magnet, but it's still a stress exam. What we need is venous, first of all, venous access on both arms, one for the infusion of adenosine and one for the administration of the contrast boluses. Our patients should be monitored throughout the test. Again, it's a stress exam, so he will have an MR-compatible blood pressure machine attached to his arm, and also an oximeter. Which stressors do we use? The classic stressor for a stress perfusion exam is adenosine. So it acts via the A1 and A2 receptors. Receptors is an agonist and causes vasodilation. We'll see a bit more in detail how adenosine works, what are the indications, contraindications, and safety issues to consider with it. There are some more novel agents, such as regadenoson, which is a selective A2A receptor agonist, and in that sense, it has a better safety profile, but some prolonged act as well. An issue to consider when we perform over time more measurements such as function and flow ones. Dobutamine CMR, it exists. So with the magnet, we can perform a dobutamine stress test. It's a clinical tool, but it happens only in high volume centers with a lot of experience. And then there is also exercise test. You can see an image here with a bicycle, MR-compatible bicycle attached to the table of the magnet. It's mainly used for research purposes. quite interesting, but also troublesome in a setting in clinical practice. So imagine that you have to install this equipment just for the stress exam, then remove it for the next one. A few more details on adenosine, which of course is not used just for MR. It's used in the lab. It's used also with nuclear tests. So people are familiar with it, but I think it's useful to highlight a few key points. So in terms of preparation, our patients should remain caffeine-free for at least 24 hours. The reason is that caffeine is an adenosine receptor antagonist, so the effect of our infusion in the body will be impaired. Then the half-time of adenosine is extremely short, 4 to 10 seconds. This is not the case with regadenosine. It has an impact in our clinical practice because if there is a contraindication with adenosine, the first thing to consider is discontinuing the infusion, expecting that any symptoms or side effect will resolve soon, while this is not the case with regadenosine, where we need to be more cautious and possibly intervene with some medications, which we'll see just after. How do we realize that the patient, we have achieved adequate vasodilation with adenosine? So first of all, what we do, the protocol is to infuse adenosine for 4 minutes at the rate of 140 microgram per kilogram per minute, and per square meter. And what we expect, in principle, is that the blood pressure will drop by 10%, the heart rate will increase by 10% as well. The patient will possibly have some minor symptoms such as flushing or chest tightness, which will tell us that there is some response, there is good response to adenosine infusion. Of course, we have to take everything into consideration. It's not always the case that these parameters will change in this manner. Some patients, a lot of them, are already on medications which can affect blood pressure or heart rate, and some of them could be in atrial fibrillation, and the response, again, cannot be sufficiently assessed just by heart rate in that case. There are some more ways of estimating that, but of course we are talking about post-processing. One of that is splenic switch off. What is that? Adenosine normally causes vasodilation in most of the organs in our body. This is less important in the hepatic and renal arteries, and it has an opposite effect in the splenic ones. So it causes vasoconstriction to the splenic ones. So what we expect if we have appropriate vasodilation is that at peak stress, the heart perfusion, the myocardial perfusion will be significantly increased, while the one in the spleen will be reduced. And in that sense, the signal in the myocardium increases in a way disproportionate to the splenic one. This is a sign, but obviously we can only estimate that on post-processing that we had achieved sufficient vasodilation. Splenic switch off cannot be used. There are studies that show that it's not a good marker of proper exercise response in cases of regadenosine or dobutamine use. What are the contraindications for a stress perfusion MR exam? So we have 3 different parts to consider. One is that we use adenosine. Second, we are talking about a stress exam. Third, we are using a magnet. With regards to the first one, adenosine should be avoided in patients who are asthmatic or with severe COPD, patients who have high degree conduction abnormalities, or these are actually the main contraindications for use of adenosine. Then we have the stress contraindications. Any stress exam should be avoided in patients who have unstable symptoms or a very recent ACS presentation. Symptomatic aortic stenosis as well, or myocardial inflammation, the classical, the traditional contraindications for a stress test. And finally, the MR-related contraindications, which are claustrophobia and allergy to the contrast agent that we use. We should consider other parameters in that, such as severe CKD as well. When any side effect happens, which are the main ones that we would expect, any persistent symptomatic high degree block, respiratory stress, distress because of the use of adenosine, and allergic reaction or angina. Depending on the complication, first of all, what we should do is to discontinue, as I said earlier, adenosine, and then, if needed, adenosine is expected its effect to resolve pretty soon in a few seconds, but if needed, there are ways of intervening further in terms of, with regards to respiratory difficulty, use of aminophylline. If there is an allergic reaction, the obvious appropriate protocol for anaphylaxis. In case of angina, obviously with nitrates, sublingual, and then also a management of any high degree conduction abnormalities. Again, when we discontinue adenosine, most of these would resolve pretty soon. Also, it's useful to mention that with appropriate preparation of the patient, and if we do go through the safety profile of the patient carefully, it will be only rarely that any of these complications will happen. And we have data from big registries in the Western world where out of 10,000 cases, there are only a handful of serious complications and no death. Right, that's how we prepare our patient. And then comes the time to acquire our images. This is the baseline stress perfusion, the perfusion protocol that we would apply. We would start with our survey, then our resting scene images. We would plan our perfusion, scan our sequence, and the way we would do that is by planning 3 short axis slices at the basal, mid-ventricular, and apical level. This will produce a 16-segment model, and we know that it corresponds and it reflects very well the overall global perfusion pattern state of the myocardium. Then we measure the blood pressure, and we start our infusion of adenosine for overall 3 minutes, but on the 3rd minute, it's time to run the sequence, the stress sequence, by continuing at the same time infusion. So we have 1 arm with adenosine infusion, the other arm we give the bolus of the contrast and expect to acquire the first pass, as we call it, the arrival of the contrast in the left ventricular cavity during a breath hold. Then there is a delay of 7 to 10 minutes, which we would fill with other sequences, such as function ones or flow ones, and until the contrast from the stress part has been washed out from the circulation, and we go for the second part, the rest one, without the same sequence, same planning, another bolus of contrast, but this time without giving adenosine. And finally, a few minutes after, we would complete our protocol with the viability study, the late enhancement images. This protocol can be squeezed or expanding depending on the clinical indication, if we focus solely on ischemia or if we need a function and viability, which is the mainstream in most of stress perfusion studies, or if we need more parts of the cardiovascular system to examine. We should not ignore that with the use of the same dose of contrast, we could practically examine in the same exam any part, if needed, all parts of the cardiovascular system. So we could include a study of inflammation, valve study, aorta study, pericardial study as well. So all this could happen in the same protocol. If when we discuss just on the routine stress perfusion protocol, this would last approximately 30 to 40 minutes with considering including the preparation of the patient. And then comes the time, once we have the images, comes the time to read those images. This so post-processing happens in clinical practice with visual analysis, and we'll go through a few examples just after to see how we read and how we assess a real defect, perfusion defect. And there is the possibility also for additional quantitative, semi, or absolute quantification. So visual assessment is the clinically established method. And there are certain criteria which have been established and which will help us in most of the cases. It's not always that easy to realize, to understand whether a perfusion defect is a real one or not, with the obvious consequences for the patient. So we want to avoid false positive or negative exams, whatever this means for the patient. So we expect that the perfusion defect, if it's a real one, if it corresponds to an epicardial lesion, it will appear once the contrast arrives first in the LV ventricle, in the left ventricle. Then it will be thicker than 1 pixel, and it will correspond to a coronary territory. It will start with a slow washing of the myocardium, pacification of the myocardium from the epicardium, but eventually it will lead in a more dense defect in the subendocardium. And it will be apparent at stress, but not at rest. With this in mind, we'll go through a few examples. So this is a normal exam, how it should appear. You've got a short axis slice. You have homogeneous, opacification of the myocardium, which occurs at the same time and pretty fast after following the arrival of the contrast in the left ventricle. Then we have a case of a single vessel disease. You will see images at 3 levels, first the apical, then the mid, and then the basal one. And we can already see that in the inferior and inferoseptal segments, there is a perfusion defect. It corresponds, considering the rules that we mentioned earlier, it corresponds to a coronary territory. It's thick enough. It starts with a slow washing from the epicardium, and it's more dense in the endocardium. And finally, it will resolve after a few cycles. It will last for approximately 5 to 4 cycles, and then it will start improving, resolving. Then it's a case of multivessel disease. Again, we have the apical slice. We can see a defect in the anterior segments, then the mid-ventricular one. And we have defects at different territories. I have taken a snapshot of that to discuss just after the video. Finally, our basal slice with defects in the way we described them earlier at 3 different territories. This is the snapshot, and what I would like to highlight here is that with MR, it's unlikely that we'll end up with a case of balanced ischemia. This is because its spatial resolution will allow to differentiate, at least to detect subtle differences between the different territories. So one defect in the circumflex area is thicker. Another one would occur a bit earlier or later. Just subtle changes in the time of the washing of the myocardium can give us the impression of whether we have balanced ischemia or circumferential microvascular dysfunction or triple vessel disease. You can also see that at the borders of the different territories, the thickness, so there is an ischemic core, and there are borders with subtle differences which allow to tell with confidence whether this is to make sure that there is no balanced ischemia, not to end up with a false negative exam. Here we have a case of fixed defect. So there is a subsegmental, predominantly subendocardial defect at stress, which is apparent also at rest. And then As we can see in the late gadolinium enhancement images, it corresponds to an existing previous scar in the same territory. So in this case, we don't talk about inducible ischemia, but a fixed defect which is produced because of the existing scar. I'll stop here to make a comment that there are some centers which have which tend to exclude the rest part from the protocol, obviously in order to minimize the scan time. However, experience is needed in order to do that. So this would only happen in high volume centers where people feel really confident to end up with a useful conclusion without the stress images. I would not recommend that to someone who starts new service from scratch or who has not been exposed to a high volume of cases in the past. And also, always our stress and rest images, we should compare them with the late gadolinium enhancement ones in the end to make sure that what we see is not a fixed defect. Because it can become more complex, as you can see in this case of peri-infarct ischemia, so 3 levels, basal, mid-ventricular, and apical one. We have a dense defect, which is a septal one, and you can see that there is a gradient near a transmural defect induced at stress in the basal slice, and then there is corresponding scar in the late gadolinium enhancement images, but which is not as thick as the perfusion defect. On top of that, we have seen that there was a slow was seen in the same territory. So the message is that we can detect the spatial resolution of MR allows us to detect for peri-infarct ischemia, and this has an obvious impact on the decision making. So it can explain the patient's symptoms. It's also a sign of either residual or recurrent ischemia in the same vessel. Then a case of microvascular dysfunction, which again, will insist the spatial resolution will allow to get nice images of slow was seen in the myocardium, which is homogeneous, it's circumferential. This is an impressive case because it's a case of a patient with hypertrophic cardiomyopathy. So we have thick muscle, and on top of that, good spatial resolution. So both these allow to get nice images of a perfusion, of a gradient, really. It's not a perfusion defect, it's a gradient, subendocardial one, circumferential, which resolves a bit earlier than the one that would be produced from an epicardial artery. And having in mind what we said a bit about triple vessel disease, we are able to distinguish between microvascular dysfunction, as in this case, and multivessel disease, possible balanced ischemia, let's say. And of course, this means that we can more objectively, on top of that, with quantification that we'll discuss just after. So having everything on the tape, we can have a thorough assessment of chest pain of potential cardiac origin, whether this is due to the epicardial arteries or to microvascular dysfunction or other causes of heart muscle disease, such as inflammation of the pericardium or the myocardium. So comprehensive assessment of any cause of chest pain of cardiac origin in the same exam with the use of the same contrast dose. Another case of HCM, this is a known hypertrophic cardiomyopathy patient. Again, at stress, it's only one slice from the mid-ventricle. We can see that there is circumferential perfusion defect, a gradient that resolves relatively soon after the arrival of the contrast in the cavity, but at the same time, there is a defect in the inferior and inferoseptal segments, which persists and is thick enough, and it's the result of a slow washing from the epicardium to the endocardium. It has all the features that we discussed earlier of an epicardial lesion, and the message is that with MR we can identify in the same exam two different types, mixed disease, so microvascular and epicardial disease on the same image. It's not always that straightforward. Quite often, we have to take everything into consideration, and still we struggle to decide whether we have a true defect or not. The most usual artifacts that can happen and that can make our life and our decision making a bit more difficult are poor breath hold artifacts. We should have in mind that perfusion sequences are sort of a cartoon making one. So you would like all the structures to be static except for the perfusion of the myocardium in order to have good quality images. So poor breath hold is a factor of potential artifacts. And then a frequent one, which is called the dark rim one, what you see in this image. And then in the next one, this is a frequent artifact that we get with stress. It's linked to either the increased heart rate in plane planning, and then mainly magnetic field inhomogeneities, which are triggered because of the arrival of the large dose of paramagnetic extravascular contrast agent in the left ventricular cavity. There are ways of distinguishing between a true defect and a dark rim one. It's not always that evident. It has specific features that help, so it will appear before the arrival of the contrast in the cavity, and it will remain dense throughout and possibly for longer than we would expect with a true epicardial defect. It's also mainly seen in the septum from between the two RV insertion points. And in principle, it's not thicker than 1 pixel wide. So these features help us to distinguish between a true and a false defect, perfusion defect. I'll go through quickly quantification. So there is a lot of discussion about perfusion quantification. It's also part of the 2021 US guidelines with a 2A indication, especially in cases of suspected microvascular dysfunction. Quantification is not new. So it has been long applied with PET and also with MR. So far with MR, it was used in with a method of semi-quantification. So we focused on the properties of the contrast, on the contrast properties, such as the time to peak signal, and then the rate, the absolute rate to peak signal. And with this, we would try and appreciate the myocardial perfusion properties of the myocardium. So it's an indirect link between contrast signal and myocardial properties. So in a normal patient, you would expect a 2 to 3-fold increase in the contrast uptake at stress, while in cases of impaired perfusion, either because of epicardial or global microvascular dysfunction, this curve is flat, such as in cases of diabetic cardiomyopathy, as you can see in this chart. We have long applied previously with Dr. Mavrogeni semi-quantification method in patients with non-ischemic cardiomyopathies, such as patients with sarcoidosis, where your stress image would not allow to detect any defect, not even a slow was in, but then with post-processing, instead of getting at stress a brighter myocardium, we can see that perfusion pattern is significantly impaired, suggestive of underlying microvascular dysfunction, which is the case also with other systemic diseases, such as systemic sclerosis. Again, in a normal patient, you would expect signal improvement and a brighter myocardium at stress, while this is impaired globally in systemic sclerosis and only at a segmental level in patients with coronary artery disease. Absolute quantification is a more novel tool. What we do there is not really to focus just on the properties of the contrast, but to try and translate the contrast properties into absolute blood flow units and measurements. It is the product of a vast amount of research. With MR, it's not that straightforward. It needs a lot of mathematical analysis and modeling, but it happens. It can be produced with the use of sophisticated software, which is available at the moment only in highly specialized centers. But in an era where post-processing becomes more and more automated, we feel that pretty soon it will be involved in clinical practice. Of course, one question that remains is to see how it will improve our diagnostic accuracy and our decision making in the end, which is the aim. Finally, a few images on perfusion in children. Children are in need of stress imaging for coronary abnormalities, either congenital or iatrogenic or even inflammatory, such as cases of Kawasaki. And MR has been long applied mainly with adenosine, but also with regadenosine has been long applied in this field as well. It comes with specific advantages, which are especially the lack of radiation. So no need for radiation in small children is a benefit. On the other hand, sometimes we may need anesthesia because of poor compliance with breath hold. So we are talking about little children. And obviously, technically, it's quite challenging, but it's feasible. I'll end this talk with this case of a giant left main aneurysm in a Kawasaki 3-year-old Kawasaki patient with involvement of the ostial LAD and circumflex. With stress MR with adenosine infusion, we can see an inducible ischemia in the lateral segments, and indeed there was a post-aneurysmal stenotic lesion at the proximal left circumflex. A key message, of course, the next speakers will get into the evidence that comes with perfusion MR. MR has a class 1 indication, both in stable and acute chest pain. It's a first-line exam. I would like to highlight that it's an established exam. It comes with specific features, advantages. The fact that there is no radiation, it's safe, it's a comprehensive exam. So we can assess different levels of the cardiovascular system at the same time. There are no limitations between the different genders, especially the limitations that we have for ischemia assessment in women. And it's one of the first indications together with myocarditis. These are the main 2 indications for an MR exam in the Western world. So it's not just the near future or something promising, but it's there. It's a first line tool. Thank you very much. Thank you.
Dr. Bratis, we thank you for your interesting, enlightening presentation. We have 2 questions from the audience. So the first one, Diana De Campos, splenic switch off can be somewhat depend on the reader. Are there any objective ways to assess it? During my CMR examination, she continues, sometimes I measure the signal intensity at rest and stress on the spleen, just for fun. Never reached a proper practical conclusion. What is your comment on that?
Well, there are some interesting studies on that with mapping. So we try based on the signal of the spleen at stress and at rest to estimate the level of vasodilation. There are some promising data with T1 mapping. This means additional scanning. So when you need to acquire mapping images before and after stress. And then one question is how accurately you can tell that you have the exact level, the expected desired level of vasodilation, how you can correspond that to the T1 signal level. Again, my suggestion is that in order to be confident that we have achieved that adequate vasodilation, we have to take everything into consideration: blood pressure, heart rate, splenic signal. Without mapping, I'm not aware of any studies of measuring the signal of the spleen without mapping sequences, just based on the stress images.
Okay.
So that's on the same note, if I may continue this question. So Dr. Bratis, as an intervention cardiologist, when I get to see CMR tests, so if I don't see a splenic switch off, is this a failed vasodilation or not?
It should raise a suspicion of a failed vasodilation, yes.
Yeah, as long as it's adenosine. But if it's a adenosine or the butamine, there's no need to...
Then we cannot rely on that. And as I said, that's why I would discuss with the EMR expert, with whoever performed the exam, to conclude. As I said, we have to take all the different details into consideration. Did the patient have any symptoms that we expect during adenosine infusion? Was the blood pressure and the heart rate sufficiently affected if the patient is not in atrial fibrillation? But on top of that, the splenic signal. So we take everything into consideration to conclude. I wouldn't just rely on one factor, but a splenic switch off is a relatively more objective one, let's say. That's why we pay more attention to that.
Yeah. So and another thing that you presented, the advantages of recadenosone, the newer vasodilator. So which is the main driver of not using recadenosone as regarding, as opposed to adenosine? Is this the cost? Is this the habit, or what is it?
So advantages of recadenosone are the fact that it's just a bolus. You don't need an infusion. Technically, it's more straightforward. It's a selective agonist, so a safer profile. In any case, you don't have that many side effects, complications, but with recadenosone, you expect even less. On the other hand, you have a higher cost, and you have a more prolonged impact on the hemodynamics. So recadenosone for at least 20 minutes will lead to significant vasodilation, and its effect, there are some studies that show that there is a subtle effect up to 2 hours after its administration. This is not a problem as long as we know that if I measure the stroke volume just after, or function, or even flow, I should have in mind that the patient is not in a resting state at that point. There is some underlying partial stress state, let's say.
Good.
Okay, and the second one from Jerome Adam. What is the use of the rest perfusion after the stress perfusion?
Well, the main idea is there are two main reasons for which we would perform rest perfusion. One is whenever there is a debate, whenever the stress exam is not straightforward one, the images are not straightforward, we have doubt, and this is not infrequent. So in 1 out of 3 cases, you will end up with some artifact or some other abnormality or some debate on the extent of ischemia, or you may even have scar in the same area. So you would like to have everything available and compare between stress and rest. That would make life easier at the cost of increased scan time. Additionally, if the discussion is about quantification, then again, you need rest. You need your resting pattern, your stress one, and then derive your parameters out of this, either semi or absolute quantitative ones.
Okay, so we thank you for one more time. Yanni?
Okay, good. So I'm happy to introduce again, as last year, Dr. Nivelt. He will present the data on CMR evaluation in acute myocardial infarction. So, Dr. Nivelt, we're all ears.
Thank you very much for the introduction. And well, I have one slightly disappointment I would like to share with you, and that's because of the location that we're in now. I'm here in the Netherlands, where it is a very rainy day and cold day. So I'm really looking forward to hopefully next year that it will be in Athens again. But for this morning, we will speak about acute myocardial infarction and the CMR evaluation of that and what it adds to the current knowledge and other parameters that you use in the clinical setting. These are my disclosures. So first we speak about the techniques and contrast kinetics in this clinical scenario. We will show a few examples and then we will speak about the additional value of CMR, which is tissue characterization in acute ischemic heart disease, and then its prognosis. And then we end with a scan protocol that you could use in patients with after an acute MI. So first we start with a summary of things that you've already learned about the pulse sequence. The pulse sequence that we use in late gadolinium enhancement in acute ischemic heart disease is a spoiled gradient we call echo pulse sequence with a 180 degrees inversion pulse to maximize T1 weighting, which means that due to the inversion pulse, we will have extra shortening of the T1 value and T1 relaxation times, and therefore we have a high signal in areas where there is contrast, shortening the T1 relaxation time compared to areas where there's less contrast or almost null contrast, where we scan at the time point where there's no signal from the normal myocardium. So in that way, necrotic tissue is bright, and we call it bright is dead, compared to the viable tissue, which is black. And these are the, I think, most important and most known papers about that by Raymond Kim's group, comparing the late enhancement images with the TTC staining, where you can see that you have a fingerprint copy on MRI with histology, which makes this technique very useful in clinical practice to see the total size of infarction, but also the transmural extent, and gives you maybe some information about functional recovery after an acute MI. So what we've learned is that there is gadolinium within the viable normal tissue with a low concentration, just a few contrast products, but there is an increased concentration of gadolinium within areas where there is myocyte necrosis, such as in acute myocardial infarction, or where there is an increased extracellular space, as in an increased collagen matrix with fibrosis, such as chronic myocardial infarction, or, for example, non-ischemic heart diseases. We will focus, of course, on the acute ischemic heart diseases, but we have to realize that the size and technique of late gadolinium enhancement critically depends on the timing after contrast injection. So as you can see here, we infuse the contrast agent, signal intensity in the blood pool rises and falls. It does the same in normal myocardium, and then it slowly distributes into the infarcted myocardium. There are some areas where the contrast doesn't ever get. For example, in thrombi, there's no contrast in thrombi, and also in areas where there is an injured microvasculature, where the diffusion of contrast is impeded, and maybe it slowly runs in that area, but not as fast as in the infarcted myocardium. So the timing after contrast injection is crucial, and normally we scan around 12 to 15 minutes after contrast injection. And as you can see here, you have a little bit of a technical challenge where you have the blood pool almost the same signal intensity as the infarcted myocardium. So you really have to carefully look at subendocardial infarcts or blood pool, because sometimes they have the same signal intensity. As you can see here in the graph, you can make your life easier if you wait a little longer, because then the signal intensity of the blood pool decreases while infarcted is still increased, or you use a little less contrast. This is a 36-year-old male with chest pain, and he came to the emergency department with more than 10 hours of symptoms. We made an echo because he said he also had symptoms of hyperventilation, and he thought that would be hyperventilation. But as soon as they made the EKG, we could see another disease. And in this echo, you can clearly see that there is a myocardial infarction of the LAD territory. Going to the cath lab, they opened the vessel again, but there was no reflow on the angiogram. And here you can see the cine images in the 4-chamber view, and here in the short axis view. And I think you can see a similar information from the echo in a short axis slice, with akinesia of the anterior and anteroseptum, and a little bit hyperkinesia of the other segments due to the short delay after the infarct. But you can also see some tissue characteristics. First of all, you can see that there's a thrombus in the apex, which was hard to see in echo because the echo view was impaired in this patient. But you can also see that there is a transmural infarction in the whole LAD territory. And here in these areas, you see a funny black line, which is not as black as the viable myocardium, but this is the area of no reflow or microvascular obstruction or microvascular injury, all the same names, all different names for the same situation. And you can also see that the infarcted area extends to the right ventricle. So you have a lot of information just in one scan, a little bit of
I am not sure that we can listen the speech of Dr. Nijveld. Is any technical problem, please?
How long was that?
Okay.
Now you can hear me?
Listen to you. Okay.
So is that for like from the beginning, or can we continue?
The last 2 minutes, I think.
Oh, funny. Okay, well, we'll just continue from here. What I just explained is that you can see this is the scan 5 days after the primary PCI, and this is 2 weeks after primary PCI. And you could see that all those features that I just summarized, microvascular obstruction, transmural extent of infarction, lead to left ventricular remodeling with wall thinning, worse LV function, and even an increased mitral regurgitation. So all those features that you normally don't see on the echo, you can get with MRI and has immediate prognostic information. Also, if you have an echo, you can see that there is akinesia, but you don't know what the chances of functional recovery after the next months. And with CMR, by using late gadolinium enhancement, you had in one glance a bit of an eyeball prognostic feeling what will happen to the patient. So, for example, in this patient where you have a small subendocardial infarct, 70% or more chance that this will fully recover, whereas in patients with transmural infarcts, there's only 15% chance of recovery of that area of akinesia. So you have prognostic information in a glance. And also, of course, you can identify whether the infarct is caused by acute coronary syndrome or a non-ischemic cause. And what we've seen in a huge study population with non-STEMI patients is that if you compare the work of the interventional cardiologists or the report of the interventional cardiologist, for example, here where they said there's no culprit stenosis, you can see with late enhancement that the troponin rise is caused by an infarct. Or in another situation where they stented the LAD, which I still feel would be a reasonable idea in this case, that the troponin rise in this patient was not caused by the LAD, but by a circumflex problem. So I think, and that's something that we see in Menoca patients quite often as well, you will see where the real infarct is or whether there an infarct is or something else like myocarditis or Takotsubo. So with all those parameters that you get from the EKG, for example, or angiography or CMR, you will have all kind of signs of microvascular injury or worse prognosis. And we studied in a paper the differences between all those measures, for example, TIMI flow, microvascular obstruction, and ST segment resolution. And we found out that if you compare those patients, that the one with microvascular obstruction really have worse prognosis. They don't benefit after a few months. They don't improve in LV function, whether they do improve in LV function if they don't have microvascular obstruction. And we could see that from all these measures, late gadolinium enhancement is the best prognosticator compared to the EKG and the angiogram. But if you want to use the EKG and the angiogram, it makes more sense to use the EKG, and then you can see that the number of Q waves is correlated to infarct size and infarct transmurality, while the residual ST segment elevation on the EKG shortly after PCI is more related to the areas of microvascular obstruction. So those features do align. And then you have another feature that you can use in MRI, which is the two-weighted imaging. T2 weighted imaging gives you an idea of the area of acute necrosis, where there is a higher water content within the myocardium. But if you closely look in this area, you can see there is a dark area as well. And this dark area corresponds to the dark area that we see here on late gadolinium enhancement. And in this patient, it's an area of microvascular obstruction, which is caused by hemoglobin breakdown products with a high iron content and doesn't give you any signal on the T2 weighted images. So if you take a closer look with histology, you can see that there's myocyte necrosis on the borders. And if you look at the center, there's microvascular injury in these patients. And we thought that microvascular injury was an area with blocked capillaries and obstructed capillaries, and that the infarcted area around it was just normal necrotic tissue. But when we took those hearts to the lab and we took a closer look, we could see that there was microthrombi and plugged capillaries in the infarcted area. But if you looked at the areas with the hypo enhancement, there was no microthrombi anymore, but there was a complete loss of vascular integrity and hemorrhage. And I think, just as we saw on the T2 weighted images, that a hemorrhage is mostly causing the dark dots on the spin echo, but also here on the late gadolinium enhancement. But the late gadolinium enhancement information is not static information, and that I will show you. And that's why we prefer to call it injury and not obstruction, because it's not obstructed. So it's not a static information, because as we've learned from the graph that I showed you previously, even in the areas of no reflow, the contrast medium slowly diffuses in. And if it slowly diffuses in, you can also understand that the area of no reflow will decrease over time. So if I look at this patient, the particular patient with an anterior infarct, you could see there's a lot of microvascular obstruction in the first image shortly after contrast injection. And if you take a closer look, you can see that those areas, they become smaller over time. So it's quite hard to state that a patient has microvascular obstruction or he or she doesn't have it. So you need to tell people that if you see microvascular obstruction, you want to know when you've seen it. And normally we make our pictures around 12 minutes, but you can understand the longer you wait, and if you still have microvascular obstruction, that will give you worse prognosis than if you only have one hint of microvascular obstruction that shortly disappears after. This image has another feature that we can explain here, and that is that it also has a mural thrombus within the heart. So late hypoenhancements, which means after 10 minutes, so not during first pass perfusion, not after 2 minutes, but after 10 minutes, is the strongest prognosticator of LV remodeling. So that makes life easier, because then you can acquire your images after your stack of short axis cines around 10 to 12 minutes. And if you see microvascular injury, you know this patient has worse prognosis. This is the study that we've done, that we compared TIMI flow with blush grade, with ST segment resolution, infarct size, infarct transmurality, and we saw that at follow-up, the change in ejection fraction over time was mostly driven by the presence of microvascular injury. And some others have studied this as well, and this is a nice paper from colleague Reinstadler, but also by Simmons, and they've looked at the extent of microvascular obstruction, and I think that's something we need to carefully think about, because as we've learned, the longer you wait, the smaller the extent will be, but this clearly shows that if you have more microvascular obstruction, you have worse prognosis. And the study by Reinstadler shows you that if you have the dark areas on T2 weighted images and you have microvascular obstruction, you have the worst prognosis. So the more injured the infarct, the more severe it's damaged, the worse prognosis. And I think that makes sense. So now we have a nice example from the daily practice. You can see that there's, again, an anterior infarct. Some funny thing is going on here. It looks a little bit like the wall is already thinning. If you look at the microvascular injury here, it's in the center of the infarct. So it's not in the cavity. So it's not a thrombus, but within the myocardium. And if you look at the T2 weighted image, you can also see that there's a dark area over there as well. So everything is aligned. And if you look at the cine images on the 2-chamber, I thought it was worth showing this because you can see that the infarct is very vulnerable here. And if we made those images and we thought, oh, this is about to burst. So that's the reason those are vulnerable infarcts. They really need close medical monitoring. And here another patient. In this patient, first the diagnosis of microvascular injury was missed, and I can show you why. These are the short axis image. Here you have the T2 weighted image. And as we know, T2 weighted imaging are images that is hard to acquire because it's a very difficult technique to make beautiful images. You can see it's a little bit white here, but there's no dark area. Here, neither. There's no dark area in the core. Then if you look at the late gadolinium enhancement images, you can see that there's some infarction, and here as well. And here you're not sure what's this, if it's microvascular injury or myocardial necrosis or thrombus. It's not very clear, but if you closely follow up this patient, so this was 1 week post-MI, and here you have the images 6 weeks post-MI, you can already see what happens. There's complete thinning of the wall. It's almost aneurysmatic, and it shows like clear dyskinesia. And even in this case, you need to do something. So this patient we operated on, and we put a patch over there. So this is dark because of the patch. It's not because of microvascular injury. And you can see that LV function is again normalized a little bit after the operation, because this situation was a little bit too tricky to keep. So in daily practice, we can use it to, if a patient, for example, has another troponin rise, to see is there a new infarct or not. And in this case, you can see that there's a little bit of extra infarct here in this part, whereas here it wasn't. And because of there's microvascular injury, you know that it should be new, because you don't see microvascular injury in old infarcts, besides the T2 weighted images, which you could also use. And you don't need to confuse it with thrombi. So thrombi are in the cavity, and microvascular injury is in the myocardium. So please pay attention to that. So now we have a little bit of debate about the T2 weighted imaging and where you should use it for. First of all, of course, you can visualize intramyocardial hemorrhage, as we've previously shown. You can also distinguish recent from old infarcts, because the acute infarcts have a higher content of water, which gives you a higher signal intensity compared to the normal myocardium. But a lot of people also feel that it can be used for measuring the area at risk. For example, here, where you have an infarct in the LAD territory, there's high signal intensity in this area, and there's lower signal intensity in the opposite area. But still, if you tweak the late gadolinium enhancement a little bit, you can see that there's late gadolinium enhancement over there as well. And people are still debating whether this could be called the area at risk. or not. And I'll show you just a few pros and cons about that. We want, of course, especially the interventional cardiologists want to know what the area at risk is, because total infarcts and total infarct size, they don't care about that, because this area of infarction can be exactly the same as this area of infarction. But the interventional cardiologist is happy to have patient B and not to have patient A. So 10 grams or 10 grams doesn't give a difference. You want to know the transmural extent of infarction. And you want to know the size of infarction compared to the whole area that was previously at risk. And first, Professor Letras proved in an animal model that T2-weighted images could be a potential technique to show this area at risk, because using late gadolinium enhancement, you could see that there's a subendocardial infarct, while on T2-weighted images, you could see the area that has edema, and it makes sense to that could be the area of risk that could be totally infarcted if you don't open the coronary artery. But as we could see from the images that I've just shown, is that it's a very tough technique to make nice images. If you change the settings of the time of acquisition of T2-weighted imaging from 450 milliseconds, for example, to 600, you could see that there's a lot of artifacts that appear or disappear, and it's very, very specific area where you have the right image with the right diagnosis. Also, you could see that if you look at the area of edema, most of the time, it's closely related to the area of infarction, and not especially following the epicardial lines as it should be if it would be the area at risk. If you check in an animal study, and this is a nice paper that's been published now, and you closely look at the fluorescent images where they depict the area at risk after closing the coronary artery, and you measure the infarct size, and you look at the late enhancement images, which is one-on-one, a fingerprint again, and then you look at the T2-weighted images, you can see that the area of high signal on T2-weighted images is much, much smaller than the area at risk as measured with fluorescent, the fluorescent technique. So I think we have to be very, very careful using T2-weighted images for the area at risk, and specifically use it to discriminate acute infarcts from chronic infarcts, because that is something that has been proven. The last 2 minutes, I'm going to show you the new techniques that we have to visualize the different specifics of the infarct. I've shown you the cine images that can, easily show the area of infarction because there's akinesia. Then you use T2-weighted images just to show where there's high signal intensity and there's a recent infarct. Sometimes it also shows a dark core, microvascular hemorrhage. And if you compare that with the late enhancement images, you can also see microvascular injury surrounded by infarcted myocardium. Also here, you can see that the T2-weighted images are completely in line with the late GAD images. New kid on the block, I think it's not new anymore, but it's T2-weighted mapping. And T2 mapping gives you a number. I think you can translate it as a number of water content, which is normal in the areas where there's normal myocardium, around 50 to 52. It's high in the area where there's high signal intensity on the T2-weighted images because there's high water content, around 82, 70 to 80 normally. But you have to be careful that in the core, it's pseudonormal because it's a mixture of hemoglobin breakdown products and edema. So it measures it out. T1 mapping does almost the same. It gives you a low number within the area of microvascular injury. It gives you a high number of the infarcted area with high water content and a normal measure within the viable normal myocardium. And finally, if you really want to study reperfusion injury, for example, if you have a new medication that prevents no reflow or prevents a reperfusion injury after primary PCI, you should use T2 star imaging, because T2 star mapping will give you a number of iron content and a number of, well, I think the severity of microvascular injury within the core of the infarct. And then the other numbers are more or less normal because there's no iron or hemoglobin breakdown products in the infarcted or the viable myocardium. It's only there in the core of the infarct if there's microvascular injury. So those are the three techniques that you could use. Normally we use them in research proposals or studies, and not for clinical practice. If you want to learn or to read more about this, there's a nice review written by Ahmet Demirkiran, which is published in European Heart Journal. It's a review where you can see the different techniques used to diagnose the different acute coronary syndrome diagnosis. And if you want to know more about the histopathology behind it, you can read this radiology review, which just been published as well. So in summary, the protocol that you could use after an acute MI, you use your standard SCOUT images, long axis images, T2 weighted imaging, just to see whether there's an acute or non-acute problem. You can also see intramyocardial hemorrhage. Then you give the contrast in a low concentration, not to give that high of a signal from the LV blood pool, short axis cines, and you end with late gadolinium enhancement. You can do it in 30 minutes, maybe even quicker. And if you want to do some research, you can also add T2 star mapping somewhere here, and T2 and native T1 maps, and after contrast injection, early gadolinium enhancement to see whether there's an LV thrombus. This is what I wanted to share with you. I hope you enjoyed the talk and learned a lot about the additional value of CMR in acute myocardial infarction. And I'm happy to hear if there's any question.
Dr. Nijveld, we really enjoyed it, and it was a learningful experience for us. You know, I'm an interventional cardiologist. Dr. Vartela is a general cardiologist, also an echocardiographer. So we learned a lot. This is one of the purposes of this meeting as well. So educate, you know, ourselves as well. So, but there are some questions from the audience. So Dr. De Campos, who is very active, I see in the query forum, she's asking about the time frame of the microvascular obstruction. What is the time frame from the acute event? For how long can we see it, and how can we track it?
Yeah, so that is a very good question. So we thought microvascular obstruction would appear, I think, with a peak around 48 hours, and then it will disappear after a day or 10, and then it will decrease over time. And we thought that if you have healed infarcts, like after 6 weeks, and that it would be totally gone. If I look at my own studies, after 3 months, I don't see any microvascular obstruction anymore. But we did a study in patients where we tested new medication, and then we had to do a CMR scan at 1 month. And at 1 month, you can still see microvascular obstruction. So, and there is some reports at the ESC conference. The group from Barcelona published data on the long persistence of microvascular obstruction. So they suggest that there might be even some areas of microvascular obstruction that persist longer than what you should histologically expect. But normally it disappears after 6 weeks.
Okay, this is very interesting. And another thing that I always, you know, sometimes, of course, we have, we talk about, we talk with echocardiographers, they presented data on and the prognostic implication of LV strain following acute MI. I suppose you can measure LV strain with CMR, right?
Yes.
So is this, how can you do it? And is this prognostic implication as well? Are there any studies that we can be aware
that's
of?
a very good. I'll add that next time to it, because there's a lot of information now about that, especially and well, I think we've learned a lot from the echo studies, because in echo LV global strain has a very strong prognostic, is a very strong prognostic marker, and it's even easier to do than MRI. But if you do MRI because of tissue-specific reasons or to look at LV thrombi or whatever, you should add also, if you see that the function is normal or, well, pretty normal, you can do LV global longitudinal strain. And if that is impaired, we know that those patients do worse. So does that also have some clinical implication? Would you then, for example, give an ACE inhibitor even if LV ejection fraction is normal? I'm not sure, but it is a tool to discriminate the good from the bad ones.
Okay, good. And there's a final question just arrived. What is the timing protocol for MRI after acute myocardial infarction, whether it's STEMI or non-STEMI, after a perfusion therapy? So can you elaborate a little bit on that?
Yeah. That's a very good question because, for example, the radiology department is always a little bit scared of having patients with stents in the MRI. And we know that you can immediately scan patient even with stents in the MRI. So that's no question. About the timing, we know that you have to be careful that, for example, if you have a patient that didn't get any reperfusion therapy and you're thinking of doing additional PCI because of an infarct, you shouldn't pay that much of attention to the transmural extent because we know it will shrink over time. So if you see, for example, a 75% transmural extent of infarction, you have to realize that it's a lot of edema. So we don't know what kind of cutoff we should use in those patients. But in non-STEMI and STEMI, I think it would be best to scan between 2 and 7 days because in that area, the situation is more or less stable.
Good. Thank you for the clarification. So thanks a lot. We learned a lot today from your talk. So I give the virtual podium to Dr. Vartela to present the next speaker. Thank you.
Thank you very much.
Nijveld, thank you. We move on in the session of CMR in coronary artery disease and cardiac remodeling. It is known that CMR has emerged as a prime player in the clinical detection of ischemic heart disease, as well in the prognosis assessment. So, Dr. Vidalakis is with us once again, an expert in MRI. Good morning.
Good morning.
He will give us information on how CMR could provide important prognostic factors valuable in everyday clinical decision-making and prognostic assessment.
Thank you very much for the invitation, and let's start. We're going to discuss about cardiac MRI for decision-making in ischemic heart disease. Here are the 3 topics that we're going to discuss in the next 30 minutes. First of all, we will talk about myocardial infarction and acute myocardial infarction and cardiac MRI. Second, we're going to discuss about myocardial viability and cardiac MRI. And last, we're going to discuss about synchronization therapy and cardiac MRI. Starting with the first topic, we will focus on how the cardiac MRI can help us to predict and reverse ventricular remodeling after an acute myocardial infarction. More or less, it's a summary of the previous presentation. As you can see in that illustration, after an acute myocardial infarction, there are 3 phases: inflammatory phase, proliferate phase, and maturation phase. All these phases, if left unchanged, lead to adverse remodeling. I would like you to pay attention on the 3rd phase, where the remote, non-infarcted myocardium is viable but dysfunctional and is subjected to inflammation and fibrosis. That leads to left ventricular chamber dilation and heart failure. This is something that we're going to discuss later about the remote viable myocardium. We're going to focus that the remote myocardium play a pivotal role for the remodeling. By using a lot of different cardiac MRI sequences and techniques, nowadays we're able to have a multi-parametric approach to diagnose and predict remodeling after acute myocardial infarction. And we need exactly this in order to optimize the treatment and assess the efficacy of the therapy that we apply to our myocardial infarction patients. Cardiac MRI allows us to calculate the ventricular volumes, masses, and ejection fractions with high reproducibility and excellent quality of images. It helps also to detect small changes in all the above parameters. That makes the cardiac MRI a powerful tool for the follow-up of our patients. Different changes of volumes and ejection fractions are detected with different infarct size and therapeutic protocols. These changes determine the clinical outcome after STEMI and strongly correlate with the myocardial damage. Unlike echocardiography, cardiac MRI can calculate volumes, masses, and ejection fractions with no assumptions. On that illustration, you see how we cut the left ventricle into 13 or more slices. These slices are cine images that allows us to mark the endocardium and the epicardium at specific cardiac phases, and by using post-processing analysis to calculate the volumes, the masses, and the ejection fraction of both ventricles and even the atria. Next cardiac MRI tool for assessing a patient with myocardial infarction is the strain images. There are plenty methods to do it, but the most used ones are the tissue tracking, the phase-based motion tracking, and the feature tracking method. The last method is the most popular for everyday clinical practice. Here are the 3 patients that underwent wall motion evaluation by using the tissue tagging method. As you can see, the patient A has hypokinesia at the anterior wall, the patient B at the lateral wall, and the patient C at the inferior wall. So this is the tissue tagging method, and this is the phase-based motion tracking technique. And here we have the most popular method, the feature tracking method. This is a post-processing technique that uses the cine images and tracks specific features on the image, just like echo with the spiral tracking technique, but with better quality of images. This table shows us how the strain of the different myocardial regions is affected during the course of an acute STEMI. The infarct region demonstrates very low strain, even up to 6 months. The regions close to the infarct region demonstrate very low strain in the first week, which improves the next 2 months, but never go back to normal. And the remote areas demonstrate slightly depressed strain on the first week after STEMI that goes back to normal soon after. In the case that the patient does not follow this pattern and the strain of the remote areas deteriorates the first 2 months after acute myocardial infarction, we can say that this patient has an adverse remodeling. As you can imagine, the evaluation of the left ventricular strain after acute myocardial infarction predicts the major cardiovascular and cerebrovascular events. When the scar is transmural, the damage of the mid-wall myocardial fibers affect their circumferential strain, and that is why this strain is the best predictor for adverse remodeling, so the circumferential strain. Moreover, the diastolic strain of the remote myocardium and the left atrial peak reservoir strain are also predictors of adverse remodeling. 10 to 20 minutes after the administration of gadolinium contrast medium, we can take heavily T1 weighted images and depict the location, the size, and the transmural extent of the scar. The scar has a bright white color due to high signal intensity that contrasts with the black healthy myocardium, as you can see on the top image. The presence of LG at the myocardium represents permanent myocardial injury and is a powerful predictor of left ventricular remodeling. With the advent of late gadolinium enhancement, the old-fashioned idea that the location of the scar determines the outcome has been abandoned. Cardiac MRI proved that the size and the transmurality of the scar, as well as the number of scars, are the most important indicators of adverse remodeling. So when the scar is more than 24% of the left ventricle, or it is transverse, the probability of adverse remodeling is very high. Moreover, the multiple scars and the existing of thrombus are also adverse prognostic indicators. So size, transmurality, and number. With a combination of LG images and edema images, we are able to calculate the myocardial salvage index. The T2 weighted images, or the contrast enhancement balance SSFP images, demonstrate the area at risk, and the LG images, the infarct size area. Most of the times, the area at risk is bigger than the infarct size area, and the difference between these two areas is the salvage myocardium. The myocardial salvage index is a very strong predictor of recovering and remodeling. It is also a powerful tool to assess the efficacy of the applying therapy. That is why it is the most popular index in trials that compare the efficacy of different therapeutic approaches. On the other hand, we need to keep in mind that the extent of edema is not always accurate and reproducible in different patients with the same infarct size. Macrovascular obstruction is another index of adverse remodeling. It is an area inside the scar with no reflow after a perfusion therapy. Many theories about the mechanism of microvascular obstruction exist, and the most popular one is the external compression of the small vessels by the edematous tissue. It is detectable 2 to 9 days after an acute myocardial infarction as dark areas inside the scar region on the LGE or early gadolinium enhancement or the first pass perfusion images. The early gadolinium enhancement is the preferred technique to uncover the early microvascular obstruction, and the very late gadolinium enhancement for the very late microvascular obstruction. Both are excellent predictors of adverse remodeling, with more specific index, of course, the very late microvascular obstruction. A more sensitive index, when it's present, for adverse remodeling is the intramyocardial hemorrhage. It is the result of capillary endothelial necrosis after a long duration of ischemia or a perfusion. The images of choice here that we can see the microvascular, the intramyocardial hemorrhage is the T2 weighted images, the T2 star weighted images, and the T2 star mapping. On these images, the intramyocardial hemorrhage is a region of low signal intensity inside the edematous tissue, as you can see on the top image. Every study has consistently and conclusively shown that intramyocardial hemorrhage is the most specific index for adverse remodeling and major cardiovascular events after an acute myocardial infarction. Different patients with method here are LGE images and T2 star mapping. Only this. But these two methods are more than enough to say the truth about our patients. The first patient has an inferior scar with no microvascular obstruction and no intramyocardial hemorrhage, as you can see. The second patient has an anteroseptal scar with a dark area inside the scar, characteristic for microvascular obstruction. And the third patient has an inferior inferolateral scar with microvascular obstruction inside the scar. And as you can see, the T2 star mapping at the areas of the scar depicts a region of low T2 star values representative for intramyocardial hemorrhage. These three patients have almost the same infarct size, but with totally different scar characteristics. So the question here is, which of them has the best or worst prognosis? According to this table, the patients without microvascular obstruction and intramyocardial hemorrhage have the best prognosis, whereas those with both microvascular obstruction and intramyocardial hemorrhage have the worst prognosis with adverse remodeling of the left ventricle. Wright-Stadler et al. Create a point system for predicting adverse remodeling. They classified their patients into three groups: low, intermediate, and high risk, according to the ejection fraction, the infarct size, the presence or no of microvascular obstruction, and the intramyocardial hemorrhage. It seems that their multi-parametric approach works pretty well. But are these four parameters enough to tell us the truth about what's going to happen to our patients after an acute myocardial infarction? Let's discuss a little bit this specific example. Here we have two patients, A and B, both with LAD occlusion. On the left images, you see the coronary angiographies. Next to them are still frames of the cine images, and next to cine images, you can see the T1 mapping of these two patients. On the right side, you can see the LG images. At first glance, someone could say that these two patients have the same myocardial damage and the prognosis must be the same. But is that true? If we analyze the similarities and the differences of these two patients, we can say that they had almost the same damage, with the same infarct size, and presence of microvascular obstruction as well. except one thing, the T1 values of the remote myocardium. Is that so important in order to tell us the truth about the patient? The answer came 6 months later. As you can read, the patient A had bigger final infarct size and left ventricular end diastolic volume index than the patient B. Also, he had a complicated course with hospitalizations and ICD-CRT implantation. So the patient with the higher T1 values of the remote myocardium developed adverse remodeling, in contrast with the other one with the lower T1 values who developed reverse remodeling, even if these two patients had the same myocardial damage. According to the most recent publications, T1 mapping of the remote myocardium is an excellent guide for anti-remodeling therapy because it can predict the prognosis after an acute myocardial infarction with high accuracy, especially in patients with more than 35% of left ventricular ejection fraction and not such a big scar. This trial proved that the patients with not such a big scar, like the patients in the first two graphs, had a prognosis which is determined mainly by T1 values of the remote myocardium. More specific, patients with higher T1 values of the remote myocardium had worse prognosis than those with normal T1 values. Similarly, the T1 values of the remote non-infarcted myocardium determine the outcome mainly in patients with left ventricular ejection fraction more than 35%. So high T1 values are an adverse prognostic index. All the previous one can be summarized at this illustration. As you can see, when the left ventricular ejection fraction is less than 35% or there is a big scar, the damage dominates the outcome. But nowadays, with the primary PCI and the treatments, a lot of patients with acute coronary syndrome have almost normal left ventricular ejection fraction and not such a big scar. For these patients, the T1 values of the remote myocardium is what dominates the outcome. So the T1 values can identify these patients that need intensified anti-remodeling therapy, and also we can monitor the response in order to have the best outcome, because the T1 values are numbers, and we can compare the numbers. All the above CMR parameters help us to assess and guide the remodeling of acute coronary disease, such as acute myocardial infarction. How cardiac MRI can help patients with chronic coronary disease, and more specific, how it can inform us about the possibility of reversing an already adverse remodeled myocardium. The magic word here is viability. By saying viable myocardium, we describe a region that is dysfunctional in rest conditions without being dead. This means that this region has a potential to revive and gain its normal function after a proper treatment. The conditions that can bring the myocardium into this situation is stanning and hibernation. Is there any point to fix every small, tiny, viable part of the myocardium? The answer is that our target is not to revive a region of the heart, but to revive our patient, which means that our target must be to improve the symptoms and the prognosis of a chronic ischemic disease patient. So before we send the patient for a viability test, we need first to confirm that he has coronary artery disease with a suitable anatomy for revascularization and symptoms of heart failure with low ejection fraction. For viability test by cardiac MRI, the question is, do the patient have enough viable myocardium to improve symptoms and life expectancy? In order to answer these questions, we need to prove that the viable myocardium is more than 20% of the total myocardium, and both the normal and the viable myocardium are more than 70% of the total myocardium. As you understand, we need a lot of viable myocardium to make the heart work again. Here we have the 4 ways to assess the viability through cardiac MRI. Most of the times, we will use a combination of these methods in order to augment our accuracy and be most confident for the results. The oldest way to assess the viability is the wall thickness. This indirect marker predicts a non-viable myocardium if the thickness of it is less than 5.5 millimeters. Even though this marker has high sensitivity, It lacks of specificity because sometimes a thinned myocardium is viable and regain its thickness after revascularization. So nowadays, we use this marker as an extra positive index on top of our classic viability test with cardiac MRI. LG images give us the opportunity to assess the extent of a scar throughout the wall thickness, the so-called transmurality. According to a lot of publications, the transmurality of a scar can give us the likelihood for a region to be viable. Even though it is not a binary parameter, for simplicity reasons, we used to say that less than 50% transmurality of a scar declares viability. As you see here, at this graph, the more transmurality, the less viability, and vice versa. This phenomenon is more obvious with the most dysfunctional segments. Low-dose dobutamine stress is another way to assess viability. It is based on the theory that the viable segments have a positive inotropic response after administration of low-dose dobutamine with improvement of wall thickening. The standing myocardium demonstrates a sustained response, whereas the hibernating myocardium a biphasic response, with improvement in low doses and deterioration in higher doses. On this table, you can see how we can separate the three types of myocardium, non-viable, standing, and hibernating, based on the rest and stress perfusion cardiac MRI, as well as the LG images and the low-dose dobutamine stress. In our department, we follow a quick protocol to uncover ischemia or viability for the dysfunction myocardium. We start with stress perfusion cardiac MRI by watching in real time how the contrast medium travels inside the myocardium after administration of regadenoson as a stressor. Then we take cine images for the function. After the cine images, we are ready to take the LG images and depict the scar because it has already passed 15 to 20 minutes from the administration of the contrast medium during the stress perfusion step. With the viability, ischemia, and dysfunctional fast protocol, we can easily diagnose the ischemic from standing or hibernating myocardium. As you see at this illustration, the hibernating myocardium demonstrates perfusion defect and most of the times subendocardial LGE with less than 50% transmurality. Here is another fast viability protocol that consists of rest cine images, LG images, and post-low dose dobutamine stress cine images. According to the low dobutamine fast protocol, we are able to detect viability by positive inotropic response, and then we can differentiate the standing from the hibernating myocardium by using the LG images. Let's see a real example of viability. Here we have a 71 years old male with symptoms of heart failure due to ischemic cardiomyopathy. He admitted to our department for cardiac MRI and viability test after he had diagnosed with total occluded LAD at the cath lab. As you see on that cine 4 chambers view, there is a global hypokinesia with low ejection fraction, but with preserved wall thickness. This is a balanced SSFP, cine short axis video of the level of papillary muscles. And here are the LGE images of short axis views in different levels. As you can see, there is subendocardium gadolinium uptake, which is not more than 50% of the wall thickness. The same impression we have with the LG images of the long axis views. Here is a viability bullseye of the patient. As you see, there are 10 viable segments, 4 non-viable, and 3 normal segments. This means that this patient has 52% of viable tissue, and he is a perfect candidate for CTO-LAD revascularization. Before we finish, we should emphasize the contribution of cardiac MRI to resynchronization therapy. Cardiac MRI can give us valuable information about the proper location of the leads in order to avoid pacing at the scar region. Also, cardiac MRI gives us the probability of having a reverse remodeling after cardiac CRT implantation. Here you can see how better is the outcome if we avoid to locate the CRT leads on top of the scar areas. The green column represents patients with no scar at both pacing locations. The yellow with scars at the right ventricular pacing location, the red at the left ventricular pacing location, and the blue column are patients with scars at both right ventricular and left ventricular pacing locations. As you see, the last group had almost zero response. In this graph, you can see how the location and the transmurality of the scar affects the response of the myocardium to resynchronization therapy. As you see, the patients with transmural scar at the left ventricle had the worst prognosis even after CRT implantation. Thank you very much.
Dr. Vitalakis, we thank you for your knowledgeable talk. I would like to ask you, do you think using MRI, can we have a better assessment of the CRT responses?
Yes, of course, because apart from the location of the leads that we can avoid locations of the scars, we also can calculate the desynchrony of the whole movement. So I think that the cardiac MRI can give us a lot of information before and even after the CRT implantation.
About the position of the electrode implantation, of course. Okay. So there is no questions from the audience. So we thank you for one more time for your knowledgeable.
Thank you.
Thank you.
Well,
So, yeah.
Yes, I think that this was a very, very important talk. We shouldn't revascularize non-viable territories. So this has been proved time and time again. So this was a very good example at the end that Dr. Vitalakis presented. So the next talk is about the additive value of CMR to other imaging modalities, and Dr. Maragiannis will be at the virtual podium. So
Good morning, everyone. Good morning from the General Military Hospital of Athens. So together we're going to talk about a very interesting subject. It's about the additive value of CMR to other imaging modalities in the evaluation of coronary artery disease. So in cardiovascular imaging, we all use in everyday practice cardiac CT, SPECT, PET, or echocardiography, usually when we want to evaluate patients with suspected coronary artery disease or patients that have already known coronary artery disease. We want to assess ischemia, viability, and of course, either in the near future or already in some hospitals, they use some hybrid techniques like combination of cardiac CT with SPECT, combination of cardiac PET with MRI, or of course combinations of cardiac PET with cardiac CT. So why do we need imaging with CMR? CMR is primarily used in the setting of chronic coronary disease in the evaluation of myocardial ischemia and of course myocardial viability. Most of the studies that most of the departments have been asked are for myocardial viability actually. With CMR, of course, we can assess replacement fibrosis with late gadolinium enhancement techniques. Of course, we can assess interstitial fibrosis with T1 mapping techniques. And of course, we can assess edema with T2 mapping techniques and stir sequences. And of course, we can evaluate valves. We can quantify regurgitations with phase contrast imaging. But why do we use CMR imaging? There is a lack of ionizing radiation. We have a very wide field of view. We can image in any desired planes we want. And of course, we can obtain identical slices with different sequences. We can have accurate measurement of ventricular volumes and of course, accurate ventricular function. We can have highly reproducible results with an excellent signal to noise ratio and of course, excellent contrast between myocardium and blood pool. And of course, the great advantage of CMR is the high spatial resolution. If you go back in the studies in the early 1999 from Duke University, Raymond Kim and his colleagues, great study in dogs. It was the first study that showed that spatial extent of hyperenhancement was the same as the spatial extent of myocardial fibrosis in specimens pathological from dogs compared with slices that have been taken with CMR. And of course, why do we care about replacement fibrosis and how do I assess it? So when we have a CMR study, we can assess very easily if a scar is ischemic or non-ischemic. An ischemic scar is usually a subendocardial infarct, subendocardial scar, or a subendocardial late gadolinium enhancement. And of course, a transmural infarct also is called ischemic. All other scars, mid-wall delayed enhancement, epicardial delayed enhancement, or even global endocardial delayed enhancement, all those are called non-ischemic patterns of scar. And using that, of course, we already know if a patient has coronary artery disease or not. Do we care about it? Of course we care, because ischemic patients do worse. They have worse prognosis, and that's why we want to know if a patient has coronary artery disease. And what about viability? All day we'll be listening about viability studies. So we know that CMR is capable of providing independent prognostic information that allows risk stratification, not only in patients that have already myocardial infarction, but of course in patients that have known coronary artery disease. Here we see an example with a patient with scar with LAD territory, where we have also a dyskinetic segment on the left. And a very nice study from the past, again from the team of Raymond Kim from Duke University, we see that patients that have akinesia on the right side of the screen or dyskinesia, then the ones that have 50 or more % of scar, then these segments have improved proctability if they are revascularized. So the ones that have more than 50%, they are not viable, so we're calling them non-viable, and the ones that have less than 50% are called viable. Especially at the category of 75 to 100%, you can see that none of the segments, 0 out of 46 segments, was viable, and there was no improvement in contractility after revascularization. There are also studies from chronic total occlusion patients that have been revascularized, and we have seen almost the same results, meaning that in segments with a scar of 25 to 75%, there was some wall thickening at 3 years. It was improved, and there was also changed wall motion thickening in segments with transmural scars, so almost the same results with the previous study. But CMR can add also more information. Traditionally, from echocardiography, we know that segments that are very thin, less than 6 millimeters, may be called like non-viable, or probably they will not recover after revascularization. That is something common that we echocardiographers know most of the time. From the other hand, here comes a very nice study from Houston Methodist, from Dr. Deepen Shah, that say that it's not exactly like that. Also, on the left panel, we have a patient before revascularization with a thin myocardial wall at the LAD territory. And you can see, of course, that not only it's thin, but also it has some kind of scar at the bottom part of the image. You can see it's about 25, maximum 50% of the total wall thickness, that scar. And probably, as we know, that scar, that specific segment would be called viable. So after revascularization, you can see that that specific patient had wall thickening of the specific segments. And of course, this, if we were going traditionally by echocardiography, in this case, we would be thinking that most probably that this patient will not have a thickening of his walls after revascularization. This study says that that CMR may identify reversible myocardial thinning. Of course, CMR has also some new sequences like dark blood imaging that allows us with a very good spatial resolution to see very small infarcts that with other traditional LG imaging techniques was not seen before. So in these cases, we can see very small subendocardial infarcts, and including we can see also papillary muscle infarctions very well. What else can MRI add us? It can add us a lot of information about microvascular obstruction. Microvascular obstruction can be seen with late gadolinium enhancement, of course, and is defined as any region of hypoenhancement within a hyperenhanced area. In this image, of course, we can see it in the middle panel, which is with early GAD images, and of course, late gadolinium images, which is the black area inside an area that is hyperenhanced. Why do we care about microvascular obstruction? We care because, again, microvascular obstruction is an independent predictor of the occurrence of major events and cardiac death in patients with STEMI. Of course, CMR can add more information, add value to other imaging modalities. How? It can assess interstitial fibrosis. We all know in ischemic cardiomyopathy that patients have myocyte loss, they have reactive cellular hypertrophy, and of course ventricular scarring. They also have diffuse fibrosis via collagen accumulation. Can we assess that? Yes, with T1 mapping is a technique that we can measure a T1 value at any given pixel before and after contrast administration. And of course, these values can represent, if they increase, of course, interstitial fibrosis. And of course, we can also measure extracellular volume fraction with the same techniques, with T1 values before and after contrast administration. Is it something valid? There are some validation techniques between T1 mapping about diffuse fibrosis, interstitial fibrosis, and specimens from pathology. Some validation exists in patients with aortic stenosis, in excised hearts undergoing transplantation, and of course in mice. Why do we care about that? Because T1 mapping in patients with coronary artery disease have more interstitial fibrosis, and this is a predictor of outcome. Of course, we also know that CMR can add more information in one study. We can have with the late gadolinium enhancement sequences, we know about SCAR, we can know about regional hormone motion abnormality with cine CMR, and of course, we can detect perfusion defects with stress CMR. You have learned already from the previous talks how to assess with stress MRI a patient, but in general, following the following algorithm that I'm showing here, you can see, for example, that if a patient has delayed, if you have LG with CMR, then probably the patient has coronary artery disease. And with stress perfusion, of course, if we find a reversible defect, then the patient has also coronary artery disease. If we see a match defect between the stress and the rest perfusion study, we call it artifact. Is stress CMR important? There are a lot of studies. For example, a negative stress test is associated with very low risk of cardiovascular death NMI and is a very good prognostic marker. There are a lot of studies. We know from studies from Euro CMR registry that CMR is very important, and people that have abnormal CMRs do worse than people that from patients that have normal CMRs, when exactly are testing patients for coronary artery disease in patients who are suspected coronary disease. We know that CMARC trial, a very important trial, that in these patients, CMR yielded a superiority over SPECT. We have also the CMARC2 trial that CMR yielded very good results regarding respect, and in the same study, CMR showed better even results. They lead to less revascularization than patients that traditionally treated with the NICE guidelines from the British Cardiology Society. We have MR Impact 2 trial, a very important trial that showed that CMR has very good sensitivity, was superior to SPECT, but specificity was inferior to SPECT. Stress CMR, a very important study from Germany, from Eike Nagel, compared to FFR. They showed that stress CMR was non-inferior to FFR and lead us to lower incidence of coronary revascularization. It was a very important study, 918 patients with high-risk features. They had typical angina or a positive, they have 2 or more cardiovascular transitional risk factors. And of course, they had, and some of them had a positive exercise limit test. So in general, there were patients with high-risk features. Revascularization was recommended in patients that had ischemia more than 6% of the LV myocardium. And in the FFR group, they were revascularized when the FFR was 0.8 or less. Meta-analysis here shows that, again, that stress CMR is very important, can be alternatively be used instead of SPECT or PET, and can have very accurate results if we want to rule out significant coronary artery disease. Of course, the traditional studies like stress echo, SPECT are very important too, and we use it in everyday practice. But with all these studies, we see that stress CMR is a technique that can be used safely, and of course, a study can provide more information together with the information that we're taking for ischemia. We can take information for viability. But what else can CMR offer us? We know everybody that the ischemic heart disease also can be seen together with problems in the valves. So we have ischemic mitral regurgitation, a very important thing. And usually echocardiographers know that ischemic mitral regurgitation is very difficult to be assessed. So most of the times, quantification with echocardiography have a lot of problems. There are technically difficult studies. We have multiple regurgitant jets. We have also discordance sometimes between echo and physical findings. In those cases, CMR is very important because it can provide us very accurate quantification of myocardial regurg. In addition, it can add us more information about the coaptation height, the annulus diameter, mitral tenting area, and other information that can be assessed with cardiac MRI. And these features can be given to our surgeons, of course, our interventionals, so everybody can have more information and in clinical decision making. So our teaching points, conclusions, is that CMR is able to assess viability without using a stress-on agent. This is very important, of course, and of course we can predict the likelihood of functional improvement. CMR is also very important because it can identify, as we said in the previous study from Houston Methodist, about reversible myocardial thinning. Of course, as we said before, it can provide accurate quantification for mitral valve regurg. Of course, we also know that interstitial fibrosis is a prognostic marker, and CMR can provide valuable information and quantify interstitial fibrosis. We can get information about microvascular obstruction, which is a very good prognostic marker in patients with STEMI. And finally, we can assess with stress CMR ischemia, which has also not only can help us in treatment management, but also has very good prognostic implications. Thank you very much. Έπεσε το ίντερνετ.
Thank you, Dr. Maragiannis. Where is my colleague? Here is my colleague, Yanni.
Okay.
Where are you?
I also faced some technical issues today, but at the end we managed.
They make things more interesting, you know, the technical issues. So it was a very nice demonstration of this, the added value of CMR to other imaging modalities. So, Dr. Maragiannis, if I may, you know, can I present, you know, a real case scenario? So I have a patient presented with a late MI, like 3 days ago, he had the pain, and he goes to the cath lab. We have an RCA occluded, we have a 45% ejection fraction with maybe a kinesis in the inferior wall. So we should not revascularize this patient, ad hoc, because a class 3 indication, we don't know if there's viability tissue or not. So please guide us through, the sequence of the examinations that we need to do. So we have all three modalities. We have stress echo available. We can do thallium test with re-ejection. We can do also CMR. So which is the best of the three? So if we have to choose one of three, and which is the time frame? Would you do, immediately? You wait for, in 5 days or what?
So our patient is the third day of myocardial infarction, or 10 days, 40 days, how what?
It's on the third day. So he had 3
And
days
we have
ago.
decided him at the third day, right?
Yeah.
With whatever modality we
Whatever,
have.
yes. Which of the three would you choose?
Okay, I'll talk about all three modalities because I'll do multimodality imaging, so I think I can have opinion about all three. So
Even better.
about gated SPECT is something that is available in most hospitals. You can find it because we have to talk about it. All colleagues that are listening do not have all modalities in their hospitals, so they may not have everything. So gated SPECT is a very good one. With this one, for example, we can have ejection fraction, we can have scar and viability. And I would say the disadvantage of SPECT is the spatial resolution. The spatial resolution of SPECT is low, meaning maybe 6-7 millimeters, so it cannot detect small scars. But transmural scars will be detected. And because if we're talking for non-viability, the ones that we care more are transmural scars. So the segments that have more than 75% or even more than 50% are the non-viable ones. So SPECT is a very good choice. We can find it, easily available, good one. Stress echo, available at bed, can be done easily, good results, good specificity, good sensitivity. I would go for it.
Somehow subjective, right? So it's not like, so someone has to know.
Yes, but subjective results. That's, I would say, the disadvantage. But in the hands of a very experienced operator, I think the results are also very good ones. But stress echo will tell us about, we can see the functional improvement of the wall motion, the thickening of the wall, and just that. We cannot see the scar, for example. So why should we choose CMR? CMR will show us the extent of the scar initially. Now, there is one problem that if the patient is at the third day, the late gadolinium enhanced will show more scar than the one that will be shown after, for example, 10 or 40 days. So the problem, if we do, if we scan the patient very early, and this has been shown in most studies, that late gadolinium enhancement will be shown in more extent of the total wall. Even the wall has edema and will be more thickened. So using, for example, the sequences that we have for edema, will show edema. Those are the T2 mapping sequences and the STIR sequences, where the myocardium will appear bright. And the third day, of course, in STEMI, we'll have edema in the area of the inferior wall, as you said, because the inferior infarction, right?
Yeah.
Yes.
So this is the third day.
Sure, the third day will show edema. At the same area, if it's a great infarct, will show a great extent, most probably more than 50% of late gadolinium enhancement. So we'll see the extent of the scar. There is a great also possibility that we'll see also microvascular obstruction. Probably you will see it in your cath lab with no reflow phenomenon. If the patient is totally, we might open the vessel, but you might see TME flow 1, 2, I don't know what the patient had. So in our language, probably we'll see microvascular obstruction, which is a bad prognostic marker.
Good.
Now, most probably we won't do a stress CMR in the third day. It's not a common practice because, for example, with viability study, we don't need we know about viability already with the extent of myocardial scar. So we don't need to stress the patient. These, I would say, are the great advantages that we in the third day that we don't need to use a stressor agent, and of course having in mind that the scar will look a little bit more than usual because we have also edema together with late gadolinium enhancement. Taking that in mind, quantifying scar, I would say if you see more than 75%, most probably this segment will be non-viable. But ideally, I would try to scan the patient later, at least 1 week on studies or even more than 10 days, at least to have less edema, and our results will be, I would say, more specific about viability and more sensitive about our question.
Excellent. So, and maybe a small final question. So, you showed very good, very nicely the capability of CMR to identify and quantify mitral regurgitation. So, do you have a special protocol in hydrating these patients, because sometimes of this, these patients are coming, fully, full diuretics, and a lot of times we have some issues with echocardiograms. There are patients that are coming and going inside the ICUs with pulmonary edemas, and they are presented with 500 milligrams of Lasix and echocardiogram. So maybe it's mitral, it's mild or moderate mitral regurgitation, but this is definitely under evaluation. Do you have a special protocol for that to have a proper quantification of the MR?
So great question about protocols. People that are performing a cardiac MRI should have also experience about valve quantification, because there are a lot of hits and tips that somebody can use in order to do quantification. So usually what most people, what we have heard in conferences, and probably we will listen about it in this conference, is in order to quantify MR, we calculate with usually with our ejection fraction, the LV stroke volume, the total stroke volume, and we also quantify with phase contrast sequences the aortic flow. And then if we don't have other valves with greater than moderate regurgitation, if we subtract from that total LV stroke volume the aortic forward flow, then with this way we'll calculate the mitral regurgitation volume and fraction. This is an easy way, but things are not so simple most of the times. Our patients have more valve regurgitations, maybe they're more sick, they have low ejection fractions. So what I really do most of the time is I usually calculate not only the aortic flow, I usually calculate other flows. I calculate also the pulmonic flow. I also calculate the mitral flow, and I also calculate ejection fraction between the left and the right ventricle. So altogether, combining all these results, doing 2 or 3 different ways of calculating MR, I'll try to find an average where the patient stands for. Of course, the problem is in patients that have arrhythmias, cardiac MRI is not the study that we want to do. The results are not reliable. So for those that have atrial fibrillation, I don't think MRI is a study that we want to. For the ones that are on sinus rhythm, cardiac MRI, I would say, is the one that I would choose when I have discrepant results, when my physical examinations is discordant with the findings in other examinations like echocardiography. And of course, if I want to quantify exactly the regurgitant volume and regurgitant fraction. However, as we know from echocardiography studies and from the guidelines, the new ones from 2021 and 2020, the European and the one from the American ones, we know that for the ischemic one, because we're talking about patients with ischemic regurgitation, which is usually either eccentric when we have low inferior infarctions, or maybe a central one when we have global remodeling with, let's say, anterior infarctions. I would say for the ones that have eccentric jets, cardiac MRI is the best choice. The problem with echocardiography, as we know, with eccentric jets is very difficult to quantify. And of course, there are a lot of other troubles with echocardiography that MRI can fix. So I would highly recommend for the ones have discrepant results, go for cardiac MRI if you have sinus rhythm.
Yeah, definitely. This is very nice tip. Thank you for that. So Vaso, can you present the next
Yes.
speaker if he's
Thank
ready?
you very much.
Yes, we continue. So, quantitative perfusion reserve by CMR differentiate moderate from severe stenosis in patients with coronary artery disease. For example, triple from single vessel disease. And this is important, an important implication for assessment of prognosis and therapeutic decision making. Dr. Androulakis, could you please come to the virtual podium as called it Dr. Iakovou before to give us a talk on this issue?
Maybe he's offline, maybe. Yeah. So there were a couple of questions that haven't been answered in the meantime. I don't know if Dr. Bratt is still available. You know. No, I think so.
There's a problem. Dr. Androulakis with the...
I'm still here if
oh, nice.
you'd like to discuss something further.
Okay, maybe, yeah, there were a couple of questions that maybe we haven't answered before.
You identified the question from
yeah.
or
The one, would 50 dynamic measurements be sufficient? And what's your recommended flow rate for the gadolinium injection? Can you answer it,
yes,
Dr. Bratis?
So that would be sufficient. And then there is the question whether it is possible to acquire on a different direction, so a four-chamber tube acquisition. The answer is that it does. It is feasible. I mean, we can plan and acquire at all three dimensions with the MRI. The question is, what are we looking for? I mean, it will be impressive. There are some cases with hypertrophic cardiomyopathy, especially with apical distribution, where demonstrating the perfusion abnormalities, which are more prominent in the hypertrophic segments, can give impressive images. But in clinical practice, we know, and it has been demonstrated with appropriate studies, that the short axis, the three-slice 16-segment short axis model, it corresponds well, and it gives a good reflection of the global myocardial pattern, and this is what we use for the assessment of the skin. But technically, it's feasible in any direction.
Good, nice. And another question that we didn't answer is, can you perform stress images in long axis slices too?
Exactly, that's what I just commented on, yes. So we can. The question is, why should we acquire on long axis? So the mainstream in clinical practice is the three-slice short axis model. Okay. But then if we, for any reason, we feel that this long axis acquisition will offer something valuable clinically, it is technically feasible. We can plan in any direction.
Good, thank you. So, Vaso, I think we can continue with Dr. Androulakis.
We continue with Dr. Androulakis, okay, because we have another question after. So, Dr. Androulakis, hello.
Hi there, good morning. Can you hear me?
Yes. So, you will talk. You will give a talk on CMR of coronary arteries, and I said before that quantitative perfusion reserved by CMR differentiates moderate from severe stenosis in patients with CAD, and that's an important implication for assessment of prognosis and therapeutic decision making. You will give us a talk on that issue.
Okay, great. First of all, I would like to thank you all. Thank you for the invitation, and I do apologize because there might be a bit of a discrepancy between my spoken language and some of the slides, which are being just in Greek as well. So just a bit about myself. I'm a multi-modality imaging doctor, and my training is been at the Royal Brompton Hospital following that training program. And I've been working in CMR the last few years, both in clinical practice and research. So the topic today is, as you said, a bit challenging, particularly for a level 1 to 2 course, bearing in mind that obviously those MRI techniques are not very well established in current clinical practice. Obviously, we know that CT is pretty good and has been throughout in the guidelines for assessment of coronary artery disease. However, I will try to shed some light to some aspects, both from the technical perspective, if I may, but also from our current understanding and knowledge. So our endeavor to image the coronary started really early on, almost in parallel with other CMR applications, both from groups in the States and Europe. So the main, can you hear me?
Can you share your screen in order to have your slide?
Am I not sharing my screen? Sorry.
No.
That's pretty odd. Okay.
We can see your presentation.
Can you see my?
Yeah, we try. Yes. This is your first slide. We can see. Okay.
Okay, great, excellent. And this was my second slide, so you didn't miss much. Are you seeing the second slide now?
Yes.
Yeah.
Yes. So you can continue. We can see them.
Excellent, thank you. So what are the main challenges? First of all, the small diameter of the vessel. Obviously, we know that it's about 2 to 5 millimeters, which obviously demands high spatial resolution. A high spatial resolution image in turn would need a high signal to noise and contrast to noise ratio, which obviously inevitably would involve higher times of acquisition, which obviously that may bring us to some more artifacts, so therefore degradation of the image. However, there are available techniques that have been striving to face those difficulties in the aim of reduction of all these aspects and improvement of the image. So this, we can see here the first few attempts of coronary visualization, and I will try to follow this progress in my presentation. So far, obviously, we can see, how was the image like 25 years ago. So the main limitations, as I said, is first of all, is time, is cardiac and respiratory motion, is spatial resolution, and noise. And by noise, I mean signal to noise and contrast to noise ratio. So obviously those limitations obviously had, of course, significant impact on the efficiency of the resolution of the image. And hence this is why essentially is why the MRI is not very well established in clinical practice. However, there are techniques nowadays that have achieved already much better spatial resolutions. There are, of course, other issues like the complex planning of these studies, the artifacts, as I said, and of course some contraindications such as metallic stents, which obviously can cause significant degradation, claustrophobia, and other known contraindications. Obviously, these are the parameters that research groups have been trying to improve over the years. In terms of image acceleration, motion correction, in the face of image reconstruction later, the simplifying of the planning, essentially the use of higher magnetic fields and the use of contrast agents is some of the attempts to make our images better. So very briefly, since we're in a CMR course, just briefly to mention some basic principles, for instance, about motion corrections. So within the ECG, we can see different cardiophases. the ECG obviously is acquired either way during the study. And here on the right, you can see the RCA, one of the coronaries, motion within the cardiac cycle. And you can see that the cardiac motion is minimized towards the end of the cardiac cycle, approximately in the 75%. And apart from that, obviously, there are other troubles, like apart from the intra-RR motion, there's the inter-RR motion, which can be secondary to variations in heart rate, respiratory variations, stress of the patients, arrhythmias, and so on. So therefore we need to target a specific portion of the cardiac cycle so that we minimize the cardiac motion, therefore its effects and impact on the image quality. Obviously, for correction of motion, we have free breathing protocols nowadays, which they use prospective ECG gating to suppress the cardiac motion artifact. However, cardiac arrhythmias also might be still a bit of a problem. Also, with regards to respiratory motion, there's correction and gating, and we used, particularly in the past, breath hold techniques to minimize that effect. However, more recently, we use various respiratory navigators. So here we can see an example of how the time of acquisition has effects on the essentially image quality. For example, the image A and E has used the smallest time of acquisition, and you can see the others how hazy they look. Also, very briefly, I'm not going to go into detail, just to briefly mention some milestones which have helped in improving image quality since, for example, the CLOS, which was first published in 2010, which is a fully automatic and efficient free breathing navigator technique. They call it continuously adaptive windowing strategy. And essentially, it's a much operator, provides much operator independence regardless of the variations of the respiratory pattern. And actually, we still use it at the Brompton nowadays with some reasonable results. More recently, we have these image-based navigation techniques, which have been implemented for respiratory motion compensation, offer a very good diagnostic performance, as you can see when compared with against the invasive angiography. So the basic principle here is to separate motion from static tissue by taking essentially a low spatial resolution image at every heart cycle before the high resolution image. And here you can see the curves of the diagnostic value of this technique in revealing lesions more than 50%, how good they are. Here is the non-contrast angiography is also a very important aspect, because obviously we don't use contrast, and this uses essentially some natural T2 differences between the blood and surrounding structures. We use FAT-SAT pre-pulses or other pre-pulses, preparation pulses, etc., to enhance essentially the relative signal of the coronary arteries. So essentially, this can distinguish between the blood from the surrounding tissues, essentially. And there are various research-based methods that are currently under development, exploiting essentially those non-contrast techniques to assess various aspects which cannot actually be assessed by the CT, such as physiological function and plaque characterization, etc. And here we can see an example of that, how pretty good visualization of both arteries is achieved. Just to mention a large meta-analysis purely on MRI data, which included hundreds of studies and around 1,600 patients by a group in Milano, which showed a sensitivity and specificity of 89 and 72%, which is decent, which increased actually by using 3 Tesla And also it showed that whole heart contrast enhanced protocols should be preferred when the aim is higher diagnostic value. So here, I just briefly to show the current protocol that we use. So obviously LV structure function, and as we know it, navigator gated free breathing techniques, the stacks, etc. Also, obviously, we try to achieve a special resolution if we can less than 1 millimeter. Fat suppression can be used with about 50 to 80 slices. Parallel imaging is preferred, and obviously contrast-based agent is optional. Here is the current indication. So we know that the current indication of MRI is much broader, but the angiography, you can see that essentially class 1 is for coronary artery anomalous aneurysms, particularly in Kawasaki disease, which we will discuss just now. Bypass graft imaging. In coronary artery disease, it's not very well established yet, and in other vasculitis also we were still investigating. So in coronary artery disease, here are some examples within those indications. We can see pretty good image quality visualization of severe lesions compared with classic angiography. And this, by the way, is done by image-based navigator, which we saw earlier. Here we can see quite impressive left main bifurcation aneurysm, how well it fits with classic angiography. For coronary artery disease, actually, there are a growing body of evidence with pretty good results. And there's a recent meta-analysis which showed that the pooled per vessel assessment revealed a sensitivity of 83.7% and a specificity of 90%, even though there was some heterogeneity within the studies. Here we can see some other examples of complex lesions proximally. And obviously the obvious advantage of MRCA is that it could be part of a broader study, which could assess the volumes, the structures, the stress functions, as you said earlier, allowing essentially for a comprehensive evaluation of the patient with known or suspected coronary artery disease. And there's another prospective study of 3 Tesla angiography versus CT, which showed that both techniques has got similar ability in revealing the lesions. So it's, as we said, in bypass grafts, obviously we can adequately visualize them with MRI. The reason is essentially because obviously these grafts are straight and have a predictable course, as well as they are larger in diameter compared to the native coronary arteries. So with the use of contrast agent and for the enhancement, the diagnostic sensitivity can go up to 95%. Also, this technique is limited because of the susceptibility artifacts, because of some metallic clips, which they often exist are there. In congenital abnormalities, obviously we know that these can lead to sudden death, particularly young individuals and athletes. Sometimes they exist in conjunction with other congenital abnormality. So here we can obviously see pretty well. We can visualize the proximal course of the coronaries, and we can identify interarterial and retroaortic coronary anomalies, which, as we know, have got higher chance for sudden cardiac death. And also at the same time, obviously, we can do the anatomical functional characterization, which can be proved pretty useful in young individuals. So in pediatric also cardiology, we have seen that MRI can reliably identify the origin and proximal cause of coronaries. Essentially, it doesn't use radiation, which also makes the technique very attractive for children, particularly for congenital conditions and for children that require follow-up, regular follow-up, etc. Obviously, with whole heart coronary, that's an established already technique, and there are some challenges, obviously, such as the children are smaller in size. We use smaller amount of contrast. They may have higher cardiac output, which also can have some effects, and obviously reduced patient cooperation can also have got some negative effects. But overall, is pretty good in this aspect of cardiology. Most importantly, in vasculitis, and particularly in Kawasaki, obviously the role of cardiac MRI and angiography for these medium vessel systemic vasculitis is very well established. As you know, Professor Mavrogianni and colleagues have contributed a lot in this research field. Obviously, Kawasaki can be associated with coronary stenosis, ectatic, obviously aneurysmal lesions, which may lead also in unstable angina, infarctions, even heart failure. Obviously, we have been offered nowadays a convincing summary of these recommendations, and we have seen that this technique can be used safely and it's very useful in these populations. Here you can see two patients from Brompton. So the panel one is a Kawasaki in a 20-year-old person, male. We can see aneurysmal dilatation of proximal RCA and LAD with previous, this patient had previous RCA infarct. And in panel two, we can see an 18-year-old male with giant aneurysms affecting both coronaries essentially. Yeah, so essentially, it's you can also see the thrombus in the second panel on the right. Another example here of proximal aneurysm, how it looks also in coronary angiography. And here is you can see another male patient with LAD and RCA aneurysms and possible thrombus in the LAD. With a single MRI study, we evaluated the coronaries, we did the stress, and we identified the presence of infarction, the stress perfusion defect, as we can see in the anterior wall area, and you can see how useful can be this technique in these populations. So essentially, back to the beginning, those four problems that we had: time, motion, resolution, and noise. As we saw, there are aspects that we have improved over the time, and image can be, as you can see, better and better over time. Hopefully, we can get the best we can do soon in future. And obviously, there are other aspects of coronary imaging visualization nowadays, and there are much research actually going on in that field. For example, focusing on the identification of high-risk coronary plaques. Essentially, we use T1 shortening effects of plaque features such as hemorrhage, calcification, which obviously is not. It doesn't allow good images, particularly for CT. Thrombus, lipid core, and thin cap fibroatheroma. So we use these features, and we have seen that there are various models that, for example, with molecular plaque imaging or hybrid imaging, that this can also be an aspect that can help distinguishing those high risk features. And in conclusion, coronary imaging, as we said, is a safe, non-radiating, non-contrast, potentially technique that is being implemented widely. and it is efficient, however, not very well established in clinical practice. There is obviously further technology that is required to convert MRI into a robust, non-invasive modality for other patients, particularly adult patients. However, on the other hand, we have a pretty well establishment of the technique in pediatric patients, particularly with congenital heart disease and certain vasculitis such as Kawasaki, which should be considered as a first-line technique in these cases. Thank you very much.
We thank you, Dr. Androulakis, for your interesting presentation. I would like to ask, in which cases would you prefer a CMR over a CT coro in an adult?
In an adult, as we said, so we need to take each person in separately. For example, there are adults that may have had contrast reaction in the past. I've been asked many times by adults not to do CT, particularly because of the contrast. I have been asked, for example, to see if it would be possible, for example, on the same study to do the structure, the volumes, and the arteries. So there's first of all, there's the individual's interest and how this can be achieved. However, I would take into account the possible anatomy. If, for example, this is a person with complex lesions that I would think that MRI is not really possible to visualize efficiently, then I wouldn't obviously waste my time in that sense, because I would then do an MRI and then I would ask the patient to do a CT secondarily. So I think it depends on the person. It depends on the previous background of the persons and what I would expect to find in that patient. If it was a patient with previous bypass surgery with a bit of a mild pain that wouldn't be very convincing for whatever significant lesion, I would think, let's do a stress MRI to see the perfusion defect. Perhaps we can do the coronaries to see if at least the grafts are patent. So I would solve my answer as well.
Okay, so individualize the decision.
Yes, I think so. Yes.
Okay, thank you. Yannis, do you have any questions? So, if you have any question, or
No, I have been covered. This was an excellent demonstration of the disadvantages of CMR as a modality in depiction of the coronary arteries, but also the advantages that it carries. So, I'm all covered. So, I think we're at the end of the session. So, if there are no other burning questions, maybe we can wrap it up.
I would like to ask a question about people with diabetes mellitus. If CMR, not only Dr. Androulakis, but people with diabetes mellitus, they have problem with their microvascular. Maybe there's a microvascular disease. They have problem with the microvascular circulation. How using CMR this can be revealed?
That's a very important question. To be honest, it is a question that I'm working on in research-based projects, essentially. So obviously, we know that there are other imaging. Obviously, we are all multimodality imaging persons. So we know that obviously other techniques may be used for this kind of problem, PET for stress PET, for example, etc. But if you ask me specifically for MRI, we have very, very good quantification techniques nowadays based on AI, and there's an ongoing research, particularly the last 3 years. And actually, I'm planning to publish some research based on that particular question: how, with some quantitative markers, we can actually distinguish microvascular angina versus territorial angina based on the blood supply problem. And there are answers, at least in research, and not obviously very well established, but there are, I think, potentially answers that are coming in future. The other thing is that we can actually see the there is obviously the pattern that we can see in quantitative techniques, but also in qualitative techniques. We can see the pattern of microvascular angina, which may fit. So obviously we can see the circumferential perfusion defect, and these actually, which can be correlated with patient symptoms, etc. So there are ways of distinguishing, not 100% accurate nowadays, but there are ways of distinguishing to a certain extent those two very important aspects, particularly for diabetic patients, as you said.
Okay, well, thank you. I think it's something that we are working on it.
Yes, absolutely.
So, Dr. Iacovo, you have, if you have any question.
No,
Hmm?
I think we should wrap it up. And it was very interesting session. We learned a lot. And, you know, the whole session covered a lot of issues that have to deal with the CMR and the interaction with imaging modalities. It covered certain scenarios like the usage of CMR in acute myocardial infarction. Gave us a lot of practical information in how to use CMR, the protocols. So there was a good discussion and also some interesting queries from the audience. And I think it was a learnful experience.
Yes, we thank all the speakers.
Okay, good. Thank you.
I think it's a break now.
Okay.
As a science company with 100 years of expertise in diagnostic imaging, Bayer are committed to developing innovative products, software and services to help you run and operate your department at a high level of care. With technologically advanced injectors for CT, cardiovascular imaging, MR and contrast media, our products are supported by our digital ecosystem with software that securely manages your detailed patient data, contrast data and scan data, enabling workflow solutions like contrast and radiation dose management and personalised smart protocolling. We offer all this with our expert service to ensure your radiology ecosystem is maintained to a high standard with remote support for rapid assistance. Our technologies come together as an end-to-end workflow solution with the aim of helping you achieve consistent scan results, increasing your diagnostic confidence and operational efficiency for the benefit of your patients.
there's no doubt a lot is changing in the interventional field. Pressure is increasing. More is asked of the team. We are treating more patients and more difficult cases with many different devices and applications that make it challenging to perform at a consistent level. So everything we do is organized to give us greater simplicity and control. We expect the same from our technology too.
Azurion was built to bring greater simplicity and also control to the interventional lab. It's not all about adding more functionality, it's adding functionality that matters in the most easy way.
During a coronary case, a lot of different systems are used, so normally you would continuously switch between systems and gathering all the information through those systems. And with Azurion, we were able to bring all those systems together in one interface. Azurion really gives you the control over the whole procedure in the coronary lab. With the one touchscreen monitor, you can operate as well the Azurion system, acquiring the angiogram and the physiology data to assess, for example, the severity of stenosis, including the IVUS data to guide and confirm your treatment, for example, your stent placement. And when you also add a feature like co-registration onto that, you are able to connect and couple the information coming from the angiogram to the information that is coming from the IVUS to confirm whether the treatment was successful or not. Integration obviously reduces the amount of cable clutter in the lab, but also improves the workflow throughout the coronary procedure. And that is important because time, of course, is critical in such a procedure. The Azurion systems allow easy repositioning of the X-ray system. While doing an angiogram, then full system APCs allows you to come back to that exact same position with just one press on a button. When a patient comes into your cath lab, nowadays he needs to be reconnected to a new patient monitor. We designed the Philips Hemo system in such a way that it connects to the IntelliVue X3 patient monitor. It then provides input to the Hemo system, and this unique combination enables continuous patient monitoring. The Hemo user interface uses Azurion's intuitive workflow approach. And besides that, clinicians can now also visualize and adapt vital signs and hemodynamic calculations at the table side. For the whole hospital staff, the procedure will become more easy. And now with the Azurion system, you can enter the patient information only once, and it will be shared across all the Philips products that you are using within that coronary procedure. That seems like a small improvement, but for the whole workflow, it really saves time and it also prevents errors to be made. What is also beneficial for the hospital is that the whole Azurion system is now running on Windows 10, which offers, of course, great benefits with respect to cybersecurity, for example. Since we have all these products in our product portfolio, we can combine them in an optimal way, create a smooth workflow throughout the coronary procedure. A coronary procedure is complex in itself, so we do all the best we can to make that simpler for the user and to hopefully create better outcomes with that. Philips is the only one that can offer this level of integration.
It's really about getting a good view on what you're doing and knowing that you're right.
When the technology in my lab collaborates as smoothly as my team, my attention is free for what matters most.
Gene Farm is a privately owned pharmaceutical company that develops, manufactures, markets, and distributes premium range generic pharmaceutical products on an international level. Originally, the company's business focus was primarily on the Greek market, where we have always sold direct to market under our own brand. We have come a long way since Gene Farm was founded in 1967, having grown from a local to an international company, respected the world over. This is largely due to focused product development, flexibility in accommodating our customers' needs, and high standards in customer service. While Gene Farm retains its position in the Greek market, having established solid relationships with local physicians and patients, its business extends globally via strategic alliances based on the development of new products. Today, our presence extends to over 90 countries through our collaboration with some of the most respected pharmaceutical companies in the world. Over the last 10 years, Gene Farm's total investment in production facilities, research, and product development totaled €58 million. We operate from our privately owned facilities spread across 12,000 square meters close to Athens. The 3 state-of-the-art manufacturing units within our plant are segregated and dedicated to the production of conventional solid dosage forms and oncology sterile liquid dosage and solid dosage forms. Gene Farm's quality assurance system, based on the strictest international standards, ensures compliance with all the regulations and specifications set by national and international legislation at all levels of manufacturing and product control. Our state-of-the-art production lines, along with the quality control procedures that are in place, comply with strict safety standards in order to deliver the highest level of quality, both of the raw materials and of the finished product. Over the years, we have gained significant experience in the regulatory affairs domain, which means that we can safely guide your candidate product through to successful submission. Gene Farm is also a leader in the injectable oncology drug sector, with one of the most advanced production lines in Europe. Through continuous investment in the training of our highly skilled personnel and the development of new and innovative products and services, Gene Farm aims to be a leader in the generics pharmaceutical industry. At Gene Farm, we care about product quality, but most importantly, we care about people. Our objective is to continue to grow while offering high-quality products and services to the global pharmaceutical market.